Hi everybody, and I am going to be reading out loud some of my UWorld notes, and I tried to make this as complete as possible. This is all based on UWorld for USMLE STEP 2 CK. So I have it all divided by subjects and by organ systems. So today we're going to be going over female reproductive systems and from the OB-GYN. So let's get right to it. So first topic is disorders of sexual development. So disorders of sexual development, we're going to categorize it by diagnosis. And you have 4 diagnoses here, which is complete androgen insensitivity syndrome, Mullerian agenesis, transverse vaginal septum, and Turner syndrome. So let's go. So complete androgen insensitivity syndrome is a 46XY karyotype. So right there, it's karyotypically a male. They have minimal to absent pubic hair on examination. Their breast development are normal, but their vagina and the upper portion of the uterus is absent. And you'll see crypt orchid testes on imaging. So what's the cause? It's an X-linked mutation of an androgen receptor. So you see a little girl on the vignette with XY karyotype. You don't have to read any further. That's complete androgen insensitivity syndrome. Okay, next one would be Mullerian agenesis. This is also known as Mayer-Rokitansky-Kuster-Hauser syndrome. That's a way more fun name to say. But I doubt they'll say that one. It's going to be Mullerian agenesis. And this is, karyotypically, it's a female, 46XX, and they have normal breast and axillary and pubic hair development. But their reproductive organs, they'll have either an absent or a rudimentary uterus. And their upper vaginas could be also absent or rudimentary. However, they do have normal ovaries. And in this case, it's caused by a hypoplastic or an absent Mullerian ductal system. So there's no formation of the Mullerian ducts, hence Mullerian agenesis. All right, next one is the transverse vaginal septum, and this is just a physical malformation there of the urogenital sinus and the Mullerian ducts. So because it's isolated to the vagina, they're going to have normal breast development, normal axillary and pubic hair. Their karyotype is going to be female at 46XX, and their uterus is going to be normal as well as their ovaries. The only thing abnormal here is their vagina, which will have a septum in it, transverse vaginal septum. Easy enough. Next one is Turner syndrome, and that is your classic 45X chromosome. So you have absence of one of the X chromosomes, so only left with one X, 45X, and that's either due to complete or partial absence of that chromosome. So it could be either there, half of it there, or partially there, or completely gone. So that's why. And breast development, it's variable depending on organ function, and you'll see widely spaced nipples, shield chest, all those nice clues that hopefully we'll all get. You also have a normal uterus and a vagina, but on imaging you will see streaked ovaries, or dried up little streaked ovaries. All right. Moving on, we have primary amenorrhea, and this is an isolated amenorrhea with well-developed secondary sexual characteristics, and this is basically normal up to 16 years old. If you have amenorrhea without proper development of secondary sexual characteristics, then you have to work that up, but only if it's after 14 years old. Before 14 years old, it's unlikely to be abnormal. So you can just say, hold off, counsel the patient or whatnot. But if they haven't had a period yet until they're 16, and there's lack of secondary sexual characteristics, then you should work it up. And the most common cause is due to an anatomical and a genetic abnormality that could affect the structures needed for menses. So there could be an abnormal uterus, an abnormal vagina, or an abnormal pair of ovaries. So how do we evaluate primary amenorrhea? So first, you do a pelvic ultrasound or a pelvic examination. You either see a uterus or you do not see a uterus. Let's say you see a uterus and they're coming in for primary amenorrhea, and you see a uterus. You want to check a serum FSH level at that point. After you check the FSH, you have to note if it's either increased or decreased. If the FSH is increased, then you want to just go ahead and do karyotyping. However, if the FSH is decreased, then you want to do a cranial MRI, because at that point you're probably thinking of a tumor or something. If the FSH is increased, then you're thinking of a karyotypic problem. However, if the patient does come in complaining of primary amenorrhea, lack of secondary sexual development, she's over 16 or 16 and over, and you see and you do not see a uterus on ultrasound, then you want to go straight into karyotyping, because it could either be a boy, 46XY, normal male, and that would be androgen insensitivity syndrome, as we said before, or it could be a normal female with testosterone levels, and that's a 46XX because she's normal. However, her Müllerian ducts have not developed, or they're abnormally developed, and that's how you work up primary amenorrhea. So let's just keep going here. Okay, the testes also are going to secrete anti-Müllerian hormone. That hormone causes regression of the Müllerian duct. So we're talking about androgen insensitivity syndrome here, which is a 46XY male. It looks like a female, it's really a male. And they have an androgen receptor defect. Their free testosterone level is going to be aromatized into estrogen, and that's why they have the breast development. Their ovaries are really cryptorchid testes, not ovaries, and those testes are going to secrete testosterone. And they're not going to have axillary or pubic hair. They're also not going to have a penis or a scrotum, or ovaries or a uterus. They're just going to have free-floating or connected cryptorchid testes that's secreting testosterone. So those testes are going to secrete the anti-Müllerian hormone, and that is going to regress the formation of the Müllerian ducts. Now the Wolffian ducts, they're going to degenerate. Fetal urogenital sinus will not be able to differentiate into a penis or a scrotum, because remember, this is karyotypically a male. So they will default to the normal developmental karyotype, or phenotype, which is a female. So they'll default into the development of a female external genitalia. Male secondary sexual characteristics are going to be minimal or absent. There's functionally going to be normal gonads, but they're cryptorchid, because the testicles will not descend, and that's because there's the process of descending is a androgen dependent process. Functionally, they're going to have cryptorchid gonads that have a 1 to 5% risk of developing a dysgerminoma or a gonadoblastoma after puberty. And in general, the benefits from undergoing gonad-stimulated puberty is, for example, to attain a normal adult height. You're going to have to outweigh the low risk of malignancy. Therefore, you'd have to take out the gonads via gonadectomy, and that should be deferred until puberty is done. So any kind of gonad surgery for these people should be deferred until after puberty. Estrogen supplementation is then going to be given after you do the gonadectomy as a source of sex hormone, and because the normal hormones have been removed. Once you remove the testes, there's not going to be any more hormones. Testosterone cannot be aromatized, so you're going to have to give them supplemental estrogen. And most patients have female gender identities. Patients should receive age-appropriate disclosure, and families should be ordered psychological and psychosocial support. Okay. Sometimes I'm going to be reading a little bit choppy because I haven't read these in a while. This is a review for myself as well. So this is a double whammy of efficacy here. All right. So bear with me if I'm a little choppy here. So anyway, next topic is 5-alpha reductase deficiency. This is testosterone that cannot be converted into a dihydrotestosterone. So they will have ambiguous genitalia, female or under-masculinized external genitalia at birth with under-virilization. So their virilization is going to be decreased. There's going to be a male internal urogenital tract due to anti-Mullerian hormone, and at puberty, they experience masculinization due to testosterone, and that's example would be an increase in the size of the phallus, muscle growth, and deepening of the voice. But there's lack of breast development with 5-alpha reductase deficiency. Next topic is Turner syndrome. Turner syndrome is one of the most common causes of primary amenorrhea, and the gold standard for the diagnosis of Turner syndrome is a karyotype analysis of 30 blood lymphocytes that are going to show 45XO. That shows a complete or partial deletion of the X chromosome. And if there's a normal karyotype, but clinically you're suspicious of Turner syndrome, you want to perform a fish examination, which is in situ hybridization, to look for mosaicism, like 45XO or 46XX, that looks a little Turner's. That's beyond the resolution of normal karyotyping. So next would be supportive investigations for comorbidities after the diagnosis is confirmed. A bone age is going to be usually delayed in Turner syndrome, and testing like a skeletal survey is going to be performed to evaluate the growth potential, because you want to see how tall they're going to be. Remember, height is something very, very important to the patient. So you want to check that out. There's going to be a thoracic magnetic resonance imaging, so a TMRI should be done in all children with Turner syndrome, especially if there's echocardiography abnormalities, and you want to look for other areas of aortic narrowing. Also, gonadal dysgenesis in Turner syndrome is associated with a high risk of malignancy, and that's about 15 to 30% of the population of Turner syndrome do go on to having a high risk of malignancy, and that will require close surveillance, and the reason why we do that gonadectomy. Okay, next is aromatase deficiency. Aromatase deficiency is a very rare genetic disorder. There's total absence or poor functioning of the enzyme aromatase, and that normally converts androgens into estrogen. So if you don't have aromatase, then you have a whole lot of androgens and not enough estrogen. So in utero, the placenta will not be able to make estrogens, causing masculinization of the mother that's going to resolve after the delivery, and then virilization of an XX child, of a female child, with normal internal genitalia, but ambiguous external genitalia. So they'll have clitoromegaly when there's high androgens in utero. Later in life, they'll have osteoporosis, a delayed puberty, undetectable circulating estrogens. So the estrogen levels will be there because some testosterone will be converted into estrogen somehow, but it's so low it'll be undetectable. And then there would be an increase in gonadotropins and polycystic ovaries. Vulvar lesions. So these are commonly tested and to me, they're a little confusing sometimes in the vignettes. So let's differentiate them. So you have Lynch planus, and this is a chronic inflammation of the skin with dystrophy, or skin dystrophy, that results in a glazed, bright, erythematous lesion on the vulva with erosive ulcerated areas. The vagina as well as extragenital sites can be involved. Versus Lynchian sclerosis. And the difference between Lynchian sclerosis and an atrophic vaginitis is the following. So in Lynchian sclerosis, you have vulvular plaques, loss of the menorah, vulvar dryness, intense pruritus, so they have intense itching and dryness of the vulva with perianal involvement. Specifically, it's like a figure 8 involvement, and this is going to spare the vagina. The treatment for Lynchian sclerosis is vaginal steroids. Versus atrophic vaginitis, and this is a vulval vaginal dryness with loss of vaginal elasticity or ruga. And you'll have thinning of the vulvular skin with loss of menorah and a decreased vaginal diameter. And the treatment here would be a low-dose vaginal estrogen. So for atrophic vaginitis, and Lynchian sclerosis, they're both going to have dryness, but Lynchian sclerosis is just vulvar, whereas vaginitis is vulva and vaginal dryness. So then you're also going to have you're going to have affected areas of the menorah and the vulvar skin, and on both of them, and they're both itchy. But Lynchian sclerosis is going to spare the vagina, versus atrophic vaginitis obviously affects the vagina. So for atrophic vaginitis, remember that's low-dose vaginal estrogen. Versus Lynchian sclerosis, it's high-potency vaginal steroids. So you can remember maybe Lynchian sclerosis, the S in sclerosis is the S in steroids for the treatment. Maybe that'll help. Probably will help me. Okay, chronic inflammatory conditions of the anal genital region. This can affect the extragenital regions like the buttocks, the lower back, underneath the breasts, the armpits, shoulders, and the abdomen. And this can affect women at any age, any kind of chronic inflammatory condition, specifically Lynchian sclerosis. The pathogenesis of Lynchian sclerosis is that it's autoimmune, and it can coexist with other autoimmune disorders like diabetes type 1 and thyroid disorders. So if you see one type of autoimmune disorder, that's the default thinking should always be to look for another type of autoimmune disorder. And anogenital symptoms would be like intense pruritus of the anus and the genitals, with dyspareunia, dysuria, and painful defecation. So this, when you see painful defecation, you can also think of other things that could lead you astray. So be careful with that. Painful defecation with intense pruritus, and pain with sex, and pain on urination is more likely Lynchian sclerosis than it would be endometriosis, for instance. And it's not associated with periods here. On physical exam, you'll see a porcelain white polygonal patch with atrophy, and examples would be either regression or obliteration of the clitoris, the labia majora, the labia minora, and a decrease in diameter of the introitus, as well as scarring, hence sclerosis, of the normal genitals. And then the vulvar skin appears thin, white, and wrinkled up like a cigarette paper. So if you see wrinkled like skin, white and patchy, with painful, dry sex history, pain on defecation, and they also have, let's say, thyroid problems, thinking Lynch sclerosis. And sclerosis, what is it? Treatment? Vaginal steroids. Okay, and then how do you diagnose vaginal sclerosis? You're going to actually want to do a punch biopsy of the lesion for definitive diagnosis and to rule out malignancy. Ouch. But yeah, that's how you do it, a punch biopsy, and it is because it is a pre-malignant diagnosis for vulvar squamous cell carcinoma. And the treatment, again, high-potency topical steroids, specifically clobetasol, it's used. You want to counsel the patient that it's not known whether it can prevent scarring and prevent squamous cell carcinoma or not. Daily use of steroids can increase the risk of skin atopy, discoloration, and stria. And cryotherapy is not first line for this. So first line for cryotherapy is genital warts, because that is one of the option choices for this question on UWorld. Is treatment is it's steroids. Okay, not cryotherapy. Patient, and also it's punch biopsy. So you want to do punch biopsy to diagnose, steroids to treat for Lynch sclerosis. Patient who develops severe adhesions and scarring due to vulvar Lynch sclerosis despite control with medication may require vulvoperineoplasty, but not vulvectomy. Okay, so you don't want to remove the vulva. You want to try to fix it with vulvoperineoplasty. Okay, and there is a picture on UWorld where it shows you a normal vagina next to a vagina with Lynch sclerosis, and you will notice that around the labia majora and the anus you see a white haze, and that's your very thin tissue paper look of it. So if you read that, it's Lynch sclerosis. All right, next one is condylomata lata, and this is caused by secondary syphilis. So a broader base, flatter surface, and lobulated or plaque-like with condylomata lata. And then you have condylomata acuminata. This is really sounding like the Lion King here, but bear with me. This is genital warts, not the Lion King, condylomata acuminata. The etiology here is HPV 6 and 11. Clinically, their features are going to be multiple pink or skin-colored lesions, and the lesions are going to range from being smooth or flattened papules to exophytic cauliflower-like growths. And most of these are going to be exophytic, like the cauliflower, and some are going to be flat and sessile. So, just saying. Treatment is either chemical treatment with podophyllin or trichloroacetic acid for the small lesions. You can do immunological treatment like imiquimod, or surgical treatment with cryotherapy, laser, or excision for the larger lesions. And you want to prevent genital warts by obviously vaccinating them and using better barrier contraception methods. So remember that genital warts, I didn't say this, but obviously this is HPV, so you want to do the HPV vaccine. Most common STD in the United States is HPV. 6 and 11 are going to cause warts, and 16 and 18 are associated with a high-grade cervical intraepithelial neoplasia and cervical cancer. So Just think of the lower numbers are going to cause the least amount of your problems. 6 and 11 is just going to cause warts, versus 16 and 18, the higher number is going to have a high-grade cervical intraepithelial neoplasia risk and cervical cancer risk. They could be external or internal vaginal lesions, as well as anogenital lesions that occur in women, and it's most often asymptomatic with itching and bleeding from the lesion that is possible. On diagnosis, it's based solely on characteristic appearance of the lesion, and the recurrence of rates are high regardless of any kind of treatment modality, so they can reoccur. All right, next one is vulvar intraepithelial neoplasm, or VIN, and this is caused by HPV, and it's either white or erythematous plaques with hyperpigmented lesions or a multifocal verruciform lesion. It's not atrophic changes. So VIN is caused by HPV, and they're hyperpigmented lesions. Okay, but they're not atrophic. They're due to verruciform lesions. All right. Vulvar cancer follows HPV infection, or VIN. So if this is not treated, it can lead to vulvar cancer or vulvar dystrophy, such as Lynch's sclerosis, like we said earlier. Typically, it's singular. A fleshy lesion on the labia majora can bleed, and it's more common in postmenopausal women. Now we're going to talk about vaginal lesions. All right, so you have atrophic vaginitis versus genitourinary syndromes of menopause. So genitourinary syndromes of menopause or atrophic vaginitis, their clinical features are vulvar or vaginal dryness, itching, dyspareunia, a narrow introitus, pallor, a decrease in elasticity, decrease in ruga, and they'll have urinary frequency as well as urgency, incontinence, and infection. So how do you treat these genital urinary syndromes of menopause, which is also known as atrophic vaginitis? With first line is vaginal moisturizers and lubricants, and second line is topical vaginal estrogen. You don't want to just go ahead and give them estrogen. You want to start off cheap and easy with a moisturizer or a lubricant for mild atrophic vaginitis, especially if they don't have any type of urinary symptoms. And second line, you'd want to give a low dose topical estrogen, and that's used for moderate to severe atrophic vaginitis with urinary symptoms, even if oral estrogen replacement is in use. So even if they're on oral estrogen, you still want to give them a topical estrogen. Estrogen location, the receptor locations are going to be in the bladder trigon, the urethra, the pelvic floor muscles, and the endopelvic fascia, so all down there. Natural, medical, or surgical causes of menopause will decrease the levels of estradiol. So medical menopause would be like pelvic radiation or chemotherapy causing menopause. Surgical causes of menopause would be like a bilateral oophorectomy. So that's what I was meaning. Or natural, that a woman's over than in their late 40s, mid to late 40s or whatnot. And this is going to cause a decrease in estradiol. Okay. In premenopausal women, smoking is going to also decrease estrogen levels. And so that's another reason not to smoke, is because you'll have decrease in estrogen levels, leading to premature menopause. And ulceration due to atrophy is unlikely. There's a visible lesion almost never occurs in isolated atrophy. So there will be no ulcerations. Urinary symptoms of low estrogen will cause atrophy of intermediate and superficial layers of the vagina and the urethral mucosa epithelium, with a decrease in urethral closure, pressure, and loss of urethral compliance, causing urinary symptoms that we just went over, and those could be either stress incontinence or urge incontinence. Urinary symptoms of incontinence and recurrent UTIs can also mimic a UTI. So you want to perform a urinalysis and cultures to differentiate the two. So incontinence and UTIs, what I wrote meant, what I'm trying to say is that your urinary incontinence and your recurrent UTIs both look the same symptomatically, so you want to do a UA regardless and a culture to differentiate them. All right, next one is an easy one, vesicovaginal fistula. So a vesicovaginal fistula is a painless, continuous leakage of urine from the vagina. It's due to various risk factors such as pelvic surgery and pelvic radiation. That's going to be the most common causes, especially in industrialized countries like the US and Europe, as well as prolonged labor, childbirth trauma, and genital urinary malignancy. These can all cause a vesicovaginal fistula. So how do you diagnose this? Is obviously through physical examination and a cystourethropscopy. So on pathophysiology, it results from basically occult bladder injury during surgery or from a tissue ischemia due to excessive surgical dissection. It could present within a month of surgery, and you want to diagnose clinically by visualization of the urine leaking into the vagina, or sometimes small areas of granulation tissue or a hole can be seen. So this will trip you up a little bit. They can tell you this. They can say that a patient's been having continuous leakage of clear fluid from the vagina, and you're wondering why. And if you visualize it, it'll actually be fistula. So that's how they present it on the vignette, is someone complaining of continuous leakage of clear fluid from their vagina, not from their urethra. All right. Also, how would you test this? With a dye or with a cystourethropscopy? And that's used to perform it's performed to detect the small fistula, which can be difficult to detect if you're just visually inspecting the area. Complications would be cystitis, and urinalysis may detect an infection. And bladder catheterization in immediate post-op periods allows a small fistula to heal, but otherwise surgical correction is going to be indicated. All right. There's also something called vaginal cuff dehiscence. Vaginal cuff dehiscence, example would be like a vaginal wound separation. That's a rare but serious post-operative complication after a hysterectomy. Although peritoneal leakage through the vagina may be seen, the apex would appear inflamed or indurated. So that's another cause of leakage of fluid. There's vaginal cuff dehiscence. But that's just wound separation. Next one is vaginismus, or genitopelvic pain penetration disorder. Now, this is a psychiatric problem. Why do I know this? Is because there's a DSM-5 criteria for this. And the DSM-5 diagnostic criteria for genitopelvic pain penetration disorder is going to be the following. So they'll have ongoing difficulties with at least one of these, either vaginal penetration during intercourse, vaginal pelvic pain during intercourse, or attempted penetration. So not even penetrating yet, just the thought of it about to penetrate gives them pain. Fear and anxiety about the pain, fear and anxiety about the anticipation of the pain during or after. And they'll have tense pelvic floor muscles during attempted vaginal penetration. So you can see why this is a psychiatric condition. At least 6 months in duration. They'll have this for at least 6 months. That seems to be not the standard, but The majority of the times there is a 6-month period of whatever, and this is one of them, which is going to cause significant distress, and it doesn't account for by other medical, mental, substance abuse, or relationship issues. So otherwise, they're normal, they're not taking any medications, they're fine with their relationship, they just have the thought of intercourse starts giving them pain and making them tense. All right, so how do you treat this? With relaxation, with Kegel exercises to relax the vaginal muscles, to insert dilators of gradual increasing size, such as fingers to etc. So anything to dilate and bring about desensitization, basically. This is also known as a female orgasmic disorder, and there's persistent delay or absence of orgasm on all or nearly all occasions of sexual activity because they don't even get to the point of sexual activity due to the thought of the pain. Female sexual interest and arousal disorder. The patient is lacking or having significant less interest in sexual activity. And that's it. All right, so next one is vaginal cancer. There's the two most common are going to be squamous cell and clear cell adenocarcinoma of the vagina. So let's start off with squamous cell. That starts off at an older age, more than 60 years old. Risk factors would be, again, the HPV 16 and 18 with a history of cervical dysplasia or cancer and cigarette use. The location of the cancer is at the upper 1/3 of the posterior vaginal wall, and both squamous and clear cell adenocarcinoma are going to cause a malodorous vaginal discharge, postmenopausal or postcoital vaginal bleeding, an irregular mass, plaque, or an ulcer on the vagina, and diagnosis is made through biopsy. For clear cell adenocarcinoma, the age here is less than 20 years old, and it's due to the risk factor of the in utero exposure of diethylstilbestrol. So mom was exposed to diethylstilbestrol while you were in utero in mom, and now you are exposed to it while you're undergoing genesis, and that's how you get it. It affects the upper 1/3 of the anterior vaginal wall, versus squamous cell is the posterior vaginal wall. So adeno, A for adeno, A for anterior vaginal wall, and both of them you want to diagnose with biopsy. All right, so squamous cell carcinoma is more common than adenocarcinoma, obviously, because of the fact that you need to have had exposure in utero to diethylstilbestrol, versus squamous cell carcinoma, no. You have to have exposure to HPV, cervical history of cervical dysplasia, cigarette use. You can see that's way more common. And the treatment is based on staging. Surgical excision can be appropriate for stage 1 or 2, and the vaginal cancer is usually a result of a metastatic cancer with direct extension from the cervix, from the vulva, or from the endometrium being more common than primary vaginal cancer. So usually what I'm saying is that vaginal cancer is a cause of metastasis to the vagina versus originating in the vagina. So metastasis always seems to be the number one answer anyway regarding the origin of a cancer. Effects of various hormones in pregnancy and lactation. So let's say you have amenorrhea in a lactating mother. So a lactating mother has increased levels of circulating prolactin. Prolactin is going to inhibit the hypothalamic gonadotropic releasing hormone production. And because that's going to be inhibited, you'll have decrease in LH and FSH. That decrease in LH and FSH is going to suppress ovulation, which is going to suppress menses. Okay, and this is also used as a contraceptive method, but it's not reliable as 50% of nursing mothers start to ovulate by 6 to 12 months. So that's one method of contraception, I guess, before 6 months, but it's not reliable. All right, placental estrogen inhibits gonadotropin secretion during pregnancy. So estrogen, high estrogen, is going to decrease gonadotropin secretion in pregnancy, and levels suddenly drop after delivery. So that's another reason why you get. We'll keep going. So that's placental estrogen. Oxytocin is important in uterine in ovulation postpartum. Increased levels in lactation, as it helps in expulsion of milk and lactiferous ducts. Okay, so we all know that it helps in lactation. And then you have your human placental lactogen, which is produced by the placenta. That's a test question. Its serum levels quickly decrease after the delivery of the placenta. Hence, human placental lactogen. Placental, if you don't have a placenta, your levels should decrease after delivery of the placenta. Human placental lactogen has an insulin antagonist effect, so it blocks insulin and plays an important role in the nutrition of the fetus by causing maternal lipolysis, so breaks down fat, and insulin resistance, thus increasing delivery of fatty acids and glucose to the fetus. Very cool. So, infertility workup. So now we're going to talk about infertility. Primary infertility is failure to conceive after a year of unprotected timed sexual intercourse in a nulliparous woman less than 35 years old. If they're more than 35 years old with infertility investigation can begin after 6 months. The male factor accounts for about 20 to 30% of infertility cases, so that's why semen analysis should be performed early in evaluation of infertile couples, as the initial screening test is going to evaluate sperm concentration, sperm motility, the morphology of the sperm, and it allows identifying azoospermia and severe oligospermia as obvious causes, because it's always the guy's fault. Cutoff values exist, but broad overlaps exist, and borderline values should be evaluated with caution. So that's that. Anovulation can be evaluated using a basal body temperature, the serum progesterone measurement, and endometrial sampling. Serum progesterone measurement is used to detect ovulation, and that should be measured in the mid-luteal phase when your progesterone levels are high. The history of pelvic inflammatory disease is an important risk factor for infertility because of it impairs the performance of hysterosalpingogram. You want to perform a hysterosalpingogram to assess the fallopian tube patency. So a hysterosalpingogram is an imaging technique where dye is injected into the fallopian tubes, and you will see if there's any type of patency or lack of patency. So it's kind of like an angio of the fallopian tube. And then laparoscopy with chromotubation can be done during laparoscopy to assess the patency of the fallopian tubes, but it's invasive and expensive, and it's not first line. I guess I wrote that, but I wouldn't have picked that anyway. Chromotubation. So what you want to do first is a hysterosalpingogram if they have a history of chlamydia or something like that. Pelvic inflammatory disease. All right, premenstrual syndrome or premenstrual dysphoric disorder. Physical examinations would be, for PMS, would be bloating, fatigue, headaches, and breast tenderness. Psychological symptoms such as anxiety, mood swings, difficulty concentrating, and a decrease in libido and irritability. Symptoms begin 1 to 2 weeks prior to menses and regress around the time of menstrual flow. The symptoms are then absent until after the next ovulation. PMDD, or premenstrual dysphoric disorder, is a severe variant of prominent irritability and anger. Many patients recognize the relation of the symptoms to the menstrual cycle. If the symptoms are irregular or vary in severity, you would want to then ask the patient to do a menstrual diary for 2 to 3 months. PMS is confirmed when the symptoms occur repeatedly and predictably in the days prior to menses, and they resolve once menses starts. If the symptoms occur irregularly and throughout the menstrual cycle, then a primary mood disorder is going to be more likely. So if they're just always moody or irregularly moody and has nothing to do with their menstrual cycles, then they're just moody. Treatment is an SSRI, such as fluoxetine. That's going to be your first-line treatment after confirmation of PMS. And it can be given intermittently during the luteal phase or throughout the cycle. They are generally safe with a favorable side effect profile. And you also want to have them reduce their caffeine use, because PMS and coffee sounds great. Just kidding. All right, infertility due to aging. So there's a significant drop in oocyte numbers, such as ovulatory reserve, which occurs in the 4th decade of life. 1 out of 5 women, 35 to 39, is no longer fertile. The evaluation is early follicular phase FSH with a clomiphene challenge test or an inhibin B levels. Next is cervical mucus characteristics in the various stages. So you want to evaluate cervical mucus as an important part of the infertility workup. So it could be either too thick or too thin. It's usually too thick. It's usually too thin, and you have problems implanting itself. Early follicular phase immediately follows menstruation. So the cervical mucus is thick, it's scant or little, and acidic, and it doesn't allow the penetration by spermatozoa. So if it's too thick, the sperm can't penetrate it. If it's too thin, it can't adhere to it. Or it could penetrate it, but can't adhere. Ovulatory phase, there's profuse, clear, and thin, in contrast to the mucus in pre- and post-ovulatory phases, which is scant, opaque, and thick. And that stretches to 6 centimeters when lifted vertically. That's called your spin Barcate test. So you just put it on your fingers and you see how the mucus, it just thins out into like a long line if you separate your fingers, and it stretches to 6 centimeters. That's when you know there's the ovulatory phase. The female is ovulating. The pH is 6.5 or greater, and that's more basic than other phases, demonstrating ferning when it's smeared on a microscope slide. So that's kind of cool. Mid and late luteal phase, ovulation has already occurred, and the mucus becomes increasingly thicker and exhibits less stretching ability. So that's inhospitable to sperm. So differential diagnosis of dysmenorrhea. So the diagnosis of dysmenorrhea. So you have primary dysmenorrhea, you have endometriosis, you have fibroids, you have adenomyosis, and pelvic congestion. So clinically, the features of primary dysmenorrhea would be crampy lower abdominal and back pain during menses and a normal physical examination. So that's just primary dysmenorrhea when somebody comes in with, my stomach and abdomen hurt and my back hurts when she's having her period. That's primary dysmenorrhea. But endometriosis is pain starts peaking before the menses, and they'll have infertility and dyspareunia. Fibroids, however, have heavy menses with clotting constipation, urinary frequency, pelvic pain and heaviness. An enlarged uterus is seen on examination, so that's all due to fibroids. Adenomyosis is dysmenorrhea with pelvic pain, and menorrhagia with a bulky, globular, tender uterus. So that's what adenomyosis is. And pelvic congestion is a dull and ill-defined pelvic ache that worsens when the patient stands, as well as dyspareunia. So dyspareunia is in a couple of these. There's pain. There's pain here everywhere. So you have to differentiate them, whether it's just back pain during menses, primary dysmenorrhea. It's pain, but they have right before menses, endometriosis. If it's pain but they're heaviness and pain, constipation and heavy menses, heaviness, that's fibroids. If it's pain, dysmenorrhea with pelvic pain, but they have a globular tender uterus that's bulky, adenomyosis, and pain that gets, and pelvic aching that's worse when they stand up, that's pelvic congestion. Okay? Now, you have two types of dysmenorrhea. You have primary dysmenorrhea, which is normal on exam, and the pain is going to be due to release of prostaglandins from the endometrium that causes the uterine contractions. So it's just release of prostaglandins that cause that endometrium to contract. The endometrium, okay, the prostaglandins stimulate the endometrium, and the endometrium then causes the uterine to contract. There, I had it right the first time. That's primary dysmenorrhea. Secondary dysmenorrhea is your endometriosis, your adenomyosis, your pelvic infection, and your uterine leiomyomas. So endometriosis is a uterosacral nodularity with adnexal tenderness, and adenomyosis is uterine tenderness and enlargement. And both are going to bleed from the ectopic endometrium. The other type of secondary dysmenorrhea is pelvic infection, which causes cervical motion tenderness, like PID, and purulent cervical discharge. This is a bacterial infection. Whenever you see purulent, that's bacterial, and it's also an inflammatory response. And finally, your uterine leiomyoma, which you'll have an irregular uterine contour. So it'll feel bumpy. It may be associated with heavy bleeding. So that's another one that you have to, fibroids and leiomyomas, they're both heavy, but leiomyoma is going to be associated with an irregular contour of the uterus, right? So primary dysmenorrhea, in recap, it's an absence of any other pathology, so there's nothing wrong with them. They just have dyspareunia and GI symptoms and pain during their first few days of menses, and that goes away as soon as the endometrial lining starts becoming thin and sloughs off. The onset generally occurs in adolescence and improves as they get older. And the treatment objective here is just to relieve the pain, because that's just disrupting the patient's life. And the treatment specifically would be NSAIDs or hormonal contraception, that's first line. NSAIDs are going to inhibit that prostaglandin synthetase. And since it inhibits prostaglandin synthetase, it decreases prostaglandins, which we saw that causes uterine contractions. And most women respond to oral medication within 3 months. All right, pelvic congestion. Remember, that's the pain that worsens when the patient stands up and is relieved when they have their menses. It's also associated with a history of sexual problems. So now we're going to go over acute abdominal pelvic pain in women. So clinically, let's talk about the diagnoses. So we have Mittelschmerz, we have ectopic pregnancy, we have ovarian torsion, ruptured ovarian cysts, and pelvic inflammatory diseases. Those are all diagnoses of acute abdominal pain or pelvic pain in women. So let's start with Mittelschmerz. I think I'm saying that right. Mittelschmerz. Yeah, I think so. That's a recurrent mild and unilateral mid-cycle pain prior to ovulation. Pain lasts a few hours to a couple of days. Ultrasound is not indicated. So that's what it is. It's pain, mid-cycle pain. So it's just pain in your pelvic pain 2 days or 2 weeks before you start ovulating, or at the end of your period or something like that. But it's mid-cycle pain. Okay, ectopic pregnancy would be amenorrhea, abdominal and pelvic pain, and vaginal bleeding with a positive beta-HCG. There's no intrauterine pregnancy because it's ectopic. It's outside the uterus. It could be in the fallopian tube or anywhere. So that's amenorrhea with amenorrhea, positive beta-HCG, but there's nothing in ultrasound. All right, next one is ovarian torsion. And when you see torsion, that's twisting, that's sudden onset of severe, unilateral, so only one side, lower abdominal pain, nausea, and vomiting. They'll always trick you and trip you up and saying that it's on the right lower quadrant. So you're thinking appendicitis, but you shouldn't, because they'll tell you this in a young female. And on ultrasound, you'll see enlarged ovaries with decrease in blood flow. But that's what you'll see, but I doubt that they'll ask you that, because that's a giveaway. But it's a sudden onset of severe unilateral lower abdominal pain, nausea, and vomiting, ovarian torsion. Now, ruptured ovarian cyst. This is a sudden onset of severe unilateral lower abdominal pain that immediately follows strenuous or sexual activity. There is free fluid near the ovarian cyst. And you have pelvic inflammatory disease that causes fevers, chills, vaginal discharge, lower abdominal pain, and cervical motion tenderness, with or without tubal ovarian abscess on ultrasound. And and now we're going to talk about these all independently. So the Mittelschmerz. This is common in women who are not taking oral contraceptives. Example would be those who are ovulating. And that's due to enlargement of the developing follicle, which irritates the peritoneum. Now we're going to talk about ectopic pregnancy. So the management of suspected ectopic pregnancy is the following. So first you would have a positive urine beta-HCG, followed by lower abdominal pain or vaginal bleeding. And you would basically try to find out if they're either hemodynamically stable or unstable. If they're unstable, then you want to just do immediate surgical consultation. But if they're stable, you want to do a transvaginal ultrasound. The transvaginal ultrasound is going to show you either an adnexal mass, an intrauterine pregnancy, or it's not diagnostic. So if on ultrasound you do see an adnexal mass, then you want to just treat the ectopic pregnancy. If you see an intrauterine pregnancy, that's a uterine pregnancy, so you're good. And you don't go any further trying to suspect an ectopic pregnancy because it's an intrauterine pregnancy. And then if it's not diagnostic, you want to check its serum beta-HCG level. If the beta-HCG level is less than 1500, then you want to repeat that beta-HCG level in 2 days. If it's more than 1500, you want to repeat the beta-HCG level just to make sure and do another transvaginal ultrasound in 2 days. So a serial beta-HCG is not needed if the transvaginal ultrasound shows an intrauterine pregnancy or an ectopic pregnancy. If a beta-HCG level is between 1500 to 2000, intrauterine pregnancy should be visible on transvaginal ultrasound. An intrauterine pregnancy is not visible at a beta-HCG of 1000, And so there's no need to repeat a transvaginal ultrasound until the level rises to 1500. So you're not going to see a pregnancy unless the beta HCG reaches 1500 anyway. Beta HCG. This is a hormone that's normally secreted by the syncytial trophoblast. That's a test question. And it's responsible for maintaining the corpus luteum. That's another test question. During early pregnancy, it's used to maintain progesterone levels until the placenta is able to produce progesterone on its own. Other biological functions of beta HCG would be like promotion of male sexual differentiation and stimulation of maternal thyroid glands. And production begins about 8 days after fertilization. Beta HCG levels normally double every 2 days to 48 hours in variable pregnancy until they peak at 6 to 8 weeks gestation and are much slower rate in ectopic and non-viable pregnancies. 2 subunits of beta HCG are your alpha HCG, which is a common analog in LH, FSH, HCG, and TSH, and then the beta subunit is unique. Sorry there. Tongue twister there. Ovarian torsion is the next topic. Ovarian torsion, risk factors would be an ovarian mass, woman of reproductive age, and infertility treatment with ovulation induction. All those can cause ovarian torsion. Clinical presentation would be a sudden onset of unilateral pelvic pain, and that's usually with voluntary guarding or peritoneal signs like rebounding or involuntary guarding if the ovary becomes necrotic. They can also have nausea and vomiting, as well as a low-grade fever, with or without a palpable adnexal mass. On ultrasound, you'll see an adnexal mass with absent Doppler flow to the ovary, and that's directed at excluding other causes of pain like an ectopic pregnancy and appendicitis. Also, you want to perform a urine pregnancy test. So you'll see lack of blood flow to the ovaries because the ovary is twisted or in torsion, and that basically impedes blood flow to that ovary, causing the pain. Treatment is through laparoscopy with detorsion. So you want to untwist that ovary to get the blood flow going again. You can also do an ovarian cystectomy and oophorectomy if there is necrosis or signs of malignancy. Ovarian torsion could be either partial or complete rotation of the ovary around the infundibulopelvic ligament, which is the suspensory ligament of the ovary, or the utero-ovarian ligament, which occludes the blood supply. And ovarian torsion is a gynecological emergency. Ovarian cyst rupture, that is most commonly found also in women of reproductive age. It could be asymptomatic. They could have nausea and vomiting, but they don't have to, as opposed to torsion, which they do. There may be light vaginal bleeding and endometrial sloughing due to the drop in ovarian hormones. So on physical exam, you'll have lower abdominal tenderness to palpation, possible adnexal mass when you have a bimanual examination, and a periumbilical ecchymosis, and that's Cullen's sign. There's going to be some bruising around the belly button, insignificant intraperitoneal bleeding. On labs, you'll see a CBC, and the pregnancy test is used to rule out an ectopic pregnancy. And management of an ovarian cyst rupture, if it's uncomplicated, like no fever, hypotension, tachycardia, or signs of hemiperitoneum or infection, then you just treat conservatively by giving them analgesics as an outpatient. But if it is complicated cyst rupture, meaning that the patient is unstable or there's significant blood in the peritoneum, then you want to do a surgical intervention. Just the rule of thumb, whenever anybody is unstable, hemodynamically unstable or whatever, it's always surgical correction, surgical intervention, intubation, or whatnot. It's something like serious now. So that's another good rule of thumb. Anovulation. Anovulation such as PCOS or Stein-Leventhal syndrome. So polycystic ovarian syndrome is anovulation due to androgen excess or ovarian cysts. The pathophysiology is that there's an abnormal secretion of GnRH. Gonadotrophic releasing hormone is going to secrete high amounts of LH and low FSH. So you'll have high LH, low FSH. The LH is going to stimulate androgen production by the ovarian theca cells, and that androgen production is going to cause hirsutism and male escutcheon, or I don't know what that means. That's what I read. I gotta look that up. Escutcheon. 1 second. Okay, so escutcheon. That's the word escutcheon just means protection, a shield of some sort, a cover. So male cover, so male protection. So I guess that means in a male they won't have obviously this. But anyway, that's kind of ridiculous. So they'll have, these patients will have PCOS will have hirsutism, acne, and androgenic alopecia. Infertile or subfertile, as menstrual cycles are frequently anovulatory, and the exact reason is not known. It's possibly due to an imbalance of LH and FSH production and insulin resistance, and that can cause amenorrhea, irregular menses, occasionally accompanied by metrorrhagia. Treatment would be ovaries that are functional, causing ovulation that can be induced by clomiphene citrate. Clomiphene citrate is an estrogen analog that improves the release of GnRH, and that will then cause an increase in FSH that improves the chances of ovulation. So clomiphene is the treatment. PCOS is also treated with metformin, which improves ovulation independently. Okay, acquired hypogonadotropic hypogonadism, the pathophysiology and function of hypothalamic amenorrhea. So, excessive physical training, so somebody who's training, marathon runner or whatnot, with a very low caloric diet or starving, weight loss, chronic illnesses, somebody who has chronic marijuana use, stress and depression, anorexia nervosa. These patients will have an increase in a hormone called ghrelin, NPY, CRH, GABA, and beta endorphins, and a decrease in leptin. So high ghrelin, low leptin. That's going to affect the hypothalamus, and in the hypothalamus it's going to decrease the levels of GnRH, which is and the pituitary is going to decrease levels of LH and FSH, and in the ovaries decrease levels of estrogen. Amenorrhea, low estrogenic state, and bone loss. So that's what's happening there when you have decreased estrogen. Excessive exercise with or without weight loss and caloric restriction is more in long distance runners. Infertility is less likely than with daily 30 to 60 minutes of aerobic exercises. So this is people who are excessively exercising. And studies have shown that fat restrictions can play a role. And this can lead to complications associated with decrease in estrogen, like infertility, vaginal atrophy, and breast atrophy, and osteopenia, that may have TFTs resembling euthyroid 6 syndrome, so low T3, very low or normal T4, very low to low normal TSH, and an increase in reverse T3. And the first line treatment is to cut down whatever stressor is causing this and decreasing the exercise intensity. But if that fails, then you want to actually, they just want to exercise excessively, and there's nothing you can do about it. Then you want to just give them pulsatile GnRH. GnRH that's pulsatile, so in waves, not continuous. Continuous actually blocks hormone release, so you want to do it pulsatile. Ovulation in the first year of menarche, in approximately 90% of cycles, are anovulatory during the first year. There's immature hypothalamic pituitary ovarian axis that may fail to produce LH and FSH proper amounts and ratios to induce ovulation, with some anovulatory cycles, and endometrium is responsive to baseline estrogen. The endometrium will then develop, which eventually sloughs off during the breakthrough phenomenon or heavy bleeding when the ovulation does occur, and this can all cause menorrhagia that lasts for more than 7 days or 80 milliliters of it. Okay, so now you have anovulation due to secondary or morbid obesity. So in ovulation secondary to morbid obesity, FSH and LH levels are normal. The ovaries are going to still produce estrogen, but the progesterone is not being produced at normal post-ovulation levels. So progesterone withdrawal menses at the end of cycles does not occur. So here, when you're morbidly obese, it's due to a progesterone problem. Okay, premature ovarian failure, by definition, primary hypogonadism in a woman under 40 may be secondary to accelerated follicular atresia, or a low initial number of primordial follicles. The causes would be like chemotherapy, radiation, mumps, oophouritis, autoimmune ovarian failure, and that's associated with autoimmune conditions like diabetes type 1, Hashimoto's thyroiditis, Addison's disease, and pernicious anemia. Turner's syndrome, Fragile X syndrome as well. Developing follicles are the main source of estrogen, and that impairs follicular development, causing primary hypogonadism. That's going to decrease levels of estrogen, and there's going to be a loss of feedback inhibition on the FSH and LH. So you'll have high levels of FSH and LH. The FSH is going to be more than the LH due to the slower clearance of FSH from the circulation. And then all patients with secondary amenorrhea should receive a pregnancy test, prolactin levels and FSH levels. There's markedly increased FSH in menopause range, and that's defined by lab assay, in a woman under 40 with more than 3 months of amenorrhea to confirm the diagnosis of premature ovarian failure. And there's no need to wait for 1 year to make the diagnosis and prevent osteoporosis at the young age. Patients also lack viable oocytes, so the only option available to allow pregnancy is in vitro fertilization using donor oocytes. So that's it. If a patient wants to become pregnant and they have premature ovarian failure, the only option left is to do in vitro fertilization. Okay, so causes of abnormal uterine bleeding. So abnormal uterine bleeding is an abnormal duration, abnormal quantity, or abnormal schedule. The menstrual bleeding that is prolonged is going to be more than 5 days, and it's heavy with more than one pad use every 2 hours with irregular frequencies. That's all abnormal, right? So abnormal uterine bleeding can be directed in either postmenopausal women or premenopausal women. So when you first want to rule out a pregnancy in all premenopausal women with abnormal uterine bleeding, so you need to do a beta HCG. But postmenopausal women, there's a high risk for endometrial cancer, and endometrial sampling or transvaginal ultrasound is going to be recommended. So a postmenopausal woman may start with a transvaginal ultrasound and then go and proceed to so you start off with a transvaginal ultrasound and then proceed to an endometrial biopsy if there's endometrial thickening found. So a transvaginal ultrasound is not sensitive in premenopause due to a variation in thickness during the cycle, but it can diagnose fibroids. So that's in postmenopausal women. Now, premenopausal women, you either have structural causes like fibroids, adenomyosis, or endometrial polyps, You have non-structural causes like coagulopathies or infections. And you have ovulatory dysfunctions like prolactinoma, a polycystic ovarian syndrome, thyroid disorder, eating disorders, or severe weight loss. This is all going to cause, or this is all going to be tested with a CBC, coagulation studies, and thyroid stimulating hormone, which are all first-line tests anyway. So next one would be prolactin levels, androgen levels, FSH, and LH. And if there's ovulatory dysfunction, then if that's suspected, like anovulation, perimenopausal, or intermittent cycles, then you want to check for those. Also, a pelvic ultrasound is done to check for structural causes of abnormal uterine bleeding. And finally, endometrial sampling is done for persistent symptoms and if you're older than 45 years old, or if they have risk factors for endometrial cancer. So that's also done if ultrasounds or prolactin levels, androgens, FSH, LH, CBC, coagulation studies, TSH are all negative. You still want to check out that endometrial sampling. Risk factors for endometrial cancer are more than 45 if they're obese, diabetic, with unopposed estrogen exposure, PCOS, early menarche, or late menopause. Continuing on, abnormal uterine bleeding. There's 4 types. Here you have 4 causes or 4 diagnoses that cause abnormal uterine bleeding. So endometriosis, number 1, this shows up as dysmenorrhea, pelvic pain, dyspareunia, and infertility. The dyspareunia, this could be caused by a normal-sized, non-tender, immobile, fixed uterus and doesn't cause heavy menstrual bleeding. Fibroids, remember the fibroids were heavy menses with or without clots, constipation, urinary frequency, pelvic pain and heaviness, irregularly enlarged uterus. Adenomyosis, remember that tender, bulky, globular uterus? That's an enlarged, soft, and mobile uterus. And the endometrial, and then you have endometrial cancer and hyperplasia with a history of obesity, nulliparity, chronic ovulation, irregular intramenstrual or postmenopausal bleeding, and a small non-tender uterus. Now we're going to talk about endometriosis. Endometriosis, clinically, their features are dyspareunia, dysmenorrhea, chronic pelvic pain if it's more than 6 months and it can be exacerbated by exercise, infertility, and dyschexia. And as we said earlier, dyschexia was pain when going to the bathroom, when defecating. So that was one of the differentials there. So dyschexia for endometriosis. Physical examination, you'll have an immobile uterus with cervical motion tenderness, an adnexal mass, an erectile vaginal septum, posterior cul-de-sac, and a uterosacral ligament nodules. Diagnosis is with direct visualization and surgical biopsy, and treatment would be medical with oral contraceptives, NSAIDs, and surgical resection. So remember that dyschexia was also found with Lynch's sclerosis or atrophic vaginitis. So those are all differentials. So just wanted to remind you there. Physical examination. Okay, we already went over this. So next one would be the management of endometriosis. If you're suspecting endometriosis because they have chronic pelvic pain, dysmenorrhea, dyschexia, or a deep dyspareunia, then you want to check for contraindications to medical therapy, if they have any. If there's any need for a definitive diagnosis, like does it have to be diagnosed right now? Is there any history of infertility? Or is there any concern for malignancy or an adnexal mass? If any of these are yes, then you want to check out a laparoscopy. If no, you want to give NSAIDs with oral contraceptives to see if that manages any of those pains that you were suspecting endometriosis. If the NSAIDs and oral contraceptives do not relieve any of this, then you want to just do the laparoscopy anyway. Now, combined estrogen and progesterone oral contraceptives are going to decrease pain by suppressing ovulation. This can result in atrophy of the endometrial tissue. However, and progesterone intrauterine device can also be used. There's no treatment needed in an asymptomatic patient. Why would you treat somebody who has no symptoms? If it's not fixed, if it's not broken, don't fix it. Laparoscopy, direct visualization, biopsy, and removal of the endometrial tissue. Repair without estrogenic suppression. There's a definitive treatment in women who have complicated childbearing. So you want to check check for hysterectomy and oophorectomy. Okay. Or not check, do a hysterectomy and oophorectomy. I'm sorry. I gotta read more carefully here. All right, so the location, quality, and the timing of the pain are unique to each patient and depends on the exact location of the implant. And that mostly starts 1 to 2 weeks prior to menses and peaks just before menstruation. It's not associated with heavy bleeding. Homogeneous cystic ovarian mass is highly suggestive of an endometrioma, which can be the only manifestation and can cause infertility. And their surgical resections of an endometrioma is usually done and improves the fertility. Okay, fibroids. Uterine leiomyoma, or fibroids. Clinically, their features are they have an increase in urinary frequency, constipation, increased pelvic pain or pressure, and secondary to compression. There's heavy, prolonged menses with clots, as we've said. Pregnancy difficulties are associated with submucosal or intramural tumors, impaired fertility, pregnancy loss, and preterm labor. There's an enlarged, irregularly sized uterus, and you want to work up a uterine leiomyoma with an ultrasound. And treatment is observation if there's no significant symptoms, or you want to just do hormone contraception, embolization, or surgery if they're symptomatic. Proliferation of smooth muscles within the myometrium is what a leiomyoma is. Submucosal and intramural especially can cause heavy menstrual bleeding. Intramural, submucosal, and intracavitary all can cause recurrent pregnancy loss. Subserosal and pedunculated lesions are more likely to cause compression of adjacent organs, and that can lead to stress incontinence. And rarely, extremely large fibroids can cause urethral impingement. So hydronephrosis and urinary retention could be a cause of leiomyoma. So treatment would be oral contraceptives. This will decrease bleeding duration and the volume, but it may not completely resolve the symptoms. Anemia may still persist and may require a transfusion and more invasive therapy like myomectomy, a uterine artery embolization, and a hysterectomy. Now, abnormal submucosal myoma. Aborting a submucosal myoma. So first, it's a firm, smooth, round mass at the cervical os, and it's clinically diagnosed. Ultrasound can be performed to assess additional fibroids, however. Symptoms would be heavy and prolonged menstrual bleeding, heavy menstrual bleeding, labor-like pains due to cervical dilation by the solid mass. And so you'd want to treat by removing that myoma, removing that mass that can be accomplished vaginally. Okay, now we are going to talk about adenomyosis. So what is adenomyosis? These are endometrial glands inside the uterine musculature. So it's kind of like endometriosis, but within the musculature. And since it's within, it's going to obviously have a uniform enlargement of the myometrium, and that causes blood to deposit in the myometrium within each cycle, and that's going to disrupt the arrangement of the myometrium, smooth muscle fibers, and it's going to interfere with normal uterine contractions. So you'll have a new onset type dysmenorrhea with very heavy menstrual bleeding that's going to soak the pad and tampon more often than every 2 hours. And that leads to a progression to chronic pelvic pain. The uterus gradually enlarges, but then remains smaller than 12 weeks and below the pubic symphysis. So how are you? So they're going to basically tell you on the vignette that you'll feel a mass below the pubic symphysis, and that it's just an enlargement there. Typically in multiparous women more than 40 years old, and so lots of pregnancies and pregnancy in patients greater than 40 years old. Diagnosis is initial diagnostic workup with a beta HCG or whatnot, and then a pelvic ultrasound is used or an MRI. Definitive diagnosis is made by surgical pathology after a hysterectomy is done. This is also the definitive treatment if hormonal methods like OCPs or levonorgestrel, intrauterine devices are unsuccessful. Obviously, to remove the problem is going to be the definitive treatment. And the most accurate is always going to be a biopsy. Those are all rules of thumbs, not for this, for everything. So biopsy to get a physical tissue sample is going to be the most definitive, the most accurate, and the most definitive treatment is always going to be to surgically remove it. All right. Next one we're going to talk about is endometrial hyperplasia. Now, the management of endometrial hyperplasia is the following. Let's say you have somebody with abnormal uterine bleeding. What do you do next? You want to biopsy the endometrium. On biopsy, if you see hyperplasia, and that hyperplasia is without atypia, meaning that it doesn't look that abnormal, then your incidence of cancer is going to be very low, less than 3%. So in this case, you'll just go straight on and do progestin therapy. However, if on biopsy of the endometrium you do see atypical signs, that means that your chances of cancer, the incidence just increased up to 30%. So at that point, if the patient is considering any types of future pregnancies, then you want to just give them progestin. But if they do not have any plans for pregnancy, or they fail medical management or decline medical management, then you have to, next best step is to actually remove it by hysterectomy. So endometrial hyperplasia is going to be a proliferation of the endometrial glands. It's going to progress to endometrial adenocarcinoma. Pathophysiology is a chronic stimulation by estrogen, like obesity and ovulation stages, without the balancing effects of progesterone. So signs and symptoms would be abnormal uterine bleeding in the peri and postmenopausal women. On workup, there'll be a biopsy. You'll need a biopsy to rule out cancer and identify severities of the hyperplasia. And you want to classify it based on histological findings. So histological findings can either be simple, complex, with atypia or without atypia. If it's simple, that means that it's just mildly crowded with cystically dilated glands. Complex histological findings would be more crowded and very disorganized glands. With atypia means that it's dangerous with very important prognostic factors for progression to cancer. And then you have without atypia, which just means that it doesn't look atypical. I remember, if it doesn't look atypical, then right there it's a very low chance of cancer. So you just go straight onto doing progestin therapy. So treatment with progesterone is used to stimulate progesterone receptors in the endometrium. That's going to cause decidualization of the stroma, and it's going to thin the endometrium. So you want to repeat that endometrial biopsy after 3 months to see if they're actually responding to that treatment. So treatment of an acute abnormal uterine bleeding. If they're abnormally bleeding acutely, then you want to evaluate for coagulation disorders if clinically appropriate. Obviously, if they're bleeding, you kind of want to check out if they're having any problems with their platelets, right? All right, then you want to test sexually active patients for pregnancy. That's a rule of thumb for any type of woman of fertile age. Check out if they're pregnant or not. Acute abnormal uterine bleeding in hemodynamically stable patients may be managed medically. So medical options. So what are the treatment options for acute abnormal uterine bleeding? This would be high dose IV or oral estrogen. In this case, it would be the conjugated type, and that's an equine or horse estrogen. Also high dose combined oral contraceptives and high dose progestin pills, as well as something called tranexamic acid. Estrogen is used to promote rapid growth of the endometrium over a denuded epithelial surface that results from prolonged heavy bleeding. And so denuded just means to be stripped away of. So they have no epithelial surface, and that results in prolonged heavy bleeding. Progesterone is given to those with contraindications to estrogen or an acute abnormal uterine bleeding due to anovulation. This stabilizes disorganized endometrial linings and prevents future growth. It's less effective once the epithelial surface has been removed. And then the tranexamic acid is an antifibrinolytic that's used in patients with contraindications to both estrogens and progesterone. And you have emergency dilation and curettage, which may be needed if medical management does fail after 24 to 36 hours. Next topic is cervical cancer. So cervical cancer screening. So we're going to go by demographics. So if they're immunocompromised or they have HIV or lupus or organ transplant patients on immunosuppressants, then the screening guidelines would be that you would want to screen for cervical cancer at the onset of sexual intercourse and every 6 months, 2 times, then annually. So basically, for the first every 6 months, you want to check for cervical cancer screening, which is basically twice on the first year, and then once annually after that. If they're less than 21 years old, there's no cervical cancer screening, regardless of onset of sexual activity. I know in some institutions they used to say that you'd want to start cervical cancer screening as soon as they have sexual activity, but no, it's not the case. There's no screening at that stage. You want to do it as soon as they hit 21 to 29, however, and then you want to check a cytology every 3 years. So let's say they get a cervical cancer screening at 21, then at 24, and then at 27, and then maybe the last one at 29, just to complete that, or at 30. And then age 30 to 65, you want to do a cytology every 3 years, or you can do a cytology plus HPV testing every 5 years. And then, so at that point, if you're over 30 between the ages of 30 to 65, you do it every 3 years. or just you test every 5 years with HPV. And then at age, if you're greater than 65, there's no screening if negative prior screenings and not high risk for cervical cancer. So if you haven't had anything, if you've had just negative tests all your life and you reach 65, it's kind of like your retirement age for cervical cancer screening. There's no more needed. And then hysterectomy with cervix is removed. There's no screening if there's no history of a high-grade precancerous lesion or cervical cancer or any kind of exposure to diethylstilbestrol, DES exposure. Nearly 50% of patients, including adolescents in the U.S., will be infected with HPV within 3 years of onset of sexual activity. And HPV infection is transient in most young women, and it's usually clear within 2 years. That's why a primary HPV testing has a lower sensitivity and a lower specificity in women that is less than 30 years old, so it's not recommended. So what are the criteria for HPV vaccination? So the HPV vaccine indications would be all girls and women between the ages of 9 to 26, regardless of sexual activity, should be vaccinated for HPV. Boys and men between the ages of 9 to 21, up to the age of 26 for men who have sex with men, should be vaccinated for HPV. And immunocompromised individuals like HIV patients between the ages of 9 to 26. And obviously HPV vaccination is not indicated in pregnant women. Okay. So, and by the way, when I mean that all girls and all women between the ages of 9 to 26, regardless of sexual activity, should be vaccinated for HPV, I also mean including those with histories of genital warts, abnormal cytologies, or a positive HPV DNA test. Okay. On cytology, you want to check a pap smear, and that pap smear is going to show abnormalities with an increasing risk of atypical squamous cells to low-grade squamous intraepithelial lesions. So to high-grade squamous intraepithelial lesions to overt malignant cells or squamous cell cancers. So that's what cytology is going to do. So what is the management of atypical squamous cells of undetermined significance, or ASCUS, or a low-grade squamous intraepithelial lesion in women ages 21 to 24? So, the management of ASCUS or LSIL in women 21 to 24. So, ASCUS or LSIL, you want to repeat the pap smear at 12 months. If at 12 months they're negative for ASCUS or negative for LSIL, you want to repeat that pap smear at 12 months again. If it's a negative pap smear twice, then you just do routine screening. If they have LSIL or ASCUS and you repeat this pap smear at 12 months and you still have ASCUS or LSIL or HSIL, you want to do a colposcopy. Okay, so atypical squamous cells are present, or atypical squamous cells represent cellular abnormalities that are more marked than simple reactive changes, but which do not meet the criteria for squamous intraepithelial neoplasms. That's the SIL, squamous intraepithelial neoplasms. These cells are not typical appearance and are therefore atypical. Okay, so categories of atypical squamous cells. The PAP diagnosis of atypical squamous cells is the most common abnormal finding during cervical cancer screening and is reported in about 5% of all cervical screening tests. There are two subtypes of atypical squamous cells. There's atypical squamous cells of undetermined significance, or ASCUS, and there's atypical squamous cells that you cannot rule out, high-grade squamous intraepithelial lesion, which is an ASCH. So, HPV infection is transient and malignant. Transformation is rare in this age group, hence HPV testing is not done between 21 to 24. HPV is done after 30, right? I believe so. Yeah, so HPV infection is transient in most young women, so that's why you'll have a lower sensitivity and specificity in women that are less than 30 years old. So it's only after 30. Okay. So HPV testing is not done, and colposcopy is done unless patient demonstrates atypical squamous cells on 3 consecutive pap smears. All right, so the management of atypical squamous cells of undetermined significance or low-grade squamous intraepithelial lesions in women more than 25 years old. So, the management of ascus in women more than 25, if they're ascus positivity, you want to check HPV testing. If they're HPV positive, easy, you do a colposcopy. If they're HPV negative, you want to repeat the pap smear and check for HPV in 3 years. So here I have a picture of a slide, and it shows basically a normal epithelium, a reactive, you have ascus, followed by LCIL, followed by atypical squamous cells that are high grade, followed by high grade squamous intraepithelial lesion. So an ascus is most commonly cervical. It's the most common cervical cytology abnormality, and the risk of invasive cancer is very low. So 40 to 60% of cases are not associated with high risk HPV. This is in contrast to atypical squamous cells that cannot rule out high grade squamous intraepithelial lesions or ASCH. That's associated with a premalignant lesion. However, a finding of atypical squamous cells requires further investigations to rule out precancerous lesions. So what is the management of a high-grade squamous intraepithelial lesion, or an HGSIL? The management is, if they're more than 25 years old, you want to do either colposcopy or you want to do a loop, electrical surgical excision procedure, or LEEP, except for postmenopausal and pregnant patients. However, you can do a colposcopy, and the colposcopy, if you see CIN 2 or 3, you want to manage per guidelines. If you do not see CIN 2 or 3 and they're 21 to 24 years old, you want to repeat the colposcopy and cytology at 6 months intervals for up to 2 years. But if they're greater than 25, you want to also manage per guidelines. So high-grade squamous intraepithelial lesion has a high risk of cancerous and precancerous disease. So colposcopic examination, colposcopy, must be done, and it shows a magnified view of the cervix, and it allows to take biopsies if needed. So what it is, a colposcopy, is basically like a microscope with a viewfinder and everything that is inserted into the vagina when the patient is with the stirrups and ready for pelvic examination. So you're just looking directly at the cervix at that point. So that's colposcopy examination. That's a magnified view of the cervix, and then it's cool about it is that you can take a sample for biopsy. However, patients that are greater than 25 years old may skip colposcopy and go directly into excision or destruction. Patients less than 25, however, have low grade usually regress and you want to excise only after colposcopy. If they're not suspicious, if there's no suspicious areas on colposcopy and the visualization is adequate, there's no need to biopsy. Again, if it's not broken, don't fix it. If there is a suspicious area, obviously take a biopsy. The biopsy is then graded as either cervical intraepithelial neoplasia types 1, 2, or 3, depending on the depth of dysplastic cells. So loop electrical surgical excision, or LEEP, is a excision of a portion of the cervix that's cone-shaped, and that includes the transformation zone of the cervix and a portion of the endocervix. And then you have something called endocervical curettage, and that's indicated when the physician cannot visualize the squamo-columnar junction during colposcopy, and there is a suspicion of a deeper lesion. So it's basically physician's choice at that point. If they believe that it's deeper, then they might go and do an endocervical curettage, which is just basically a deeper scooping of the cervix to remove it. However, it's obviously contraindicated in pregnancy. High-grade squamous intraepithelial lesions in a pregnant patient, you'd want to manage the abnormal pap smear during pregnancy conservatively. So approximately 50% of high-grade squamous intraepithelial lesions and CIN2 and 3 will basically regress spontaneously during pregnancy and have a less than 0.5%, and then less than 0.5% will progress to invasive cancer. And then treatment may result in a hemorrhage and pregnancy loss. So obviously if you treat that by curettage or LEEP, you're gonna thin out that floor where that placenta is, the baby's at. So you have a risk of perforating that and losing and aborting the child. So that's why you don't do it. If there's high-grade squamous intraepithelial lesions on initial colposcopy, must be done to exclude invasive disease. Negative colposcopy, you want to repeat the pap smear and colposcopy at least 6 weeks after delivery. And if they're abnormal colposcopy, you want to biopsy any suspicious areas. So regardless if they're pregnant or not, you can still do the colposcopy because you're just looking at the cervix. It's just, you're not doing any harm there. And if you even see some type of abnormality, you just go ahead and biopsy it. Because again, getting a little piece of tissue is not the same as scooping out an entire part of the cervix. So it's better to biopsy if it's suspicious regardless of pregnancy or not. But it's not cool to treat a patient for this while they're pregnant. Just remember that. CIN2 or 3, you want to repeat cytology and biopsy not more frequently than every 12 weeks. And all sexually active women less than 25 and pregnant women should be screened for chlamydia and gonorrhea regardless. So ovarian cancer, we're going to talk about BRCA mutations in ovarian cancer. So this is divided into genetics, the cancer risks, and risk modification. So genetics, the BRCA1 and BRCA2 mutations have an autosomal dominance pattern of inheritance, and it's also seen with Ashkenazi Jews. And the cancer risk would be premenopausal epithelial ovarian cancer, fallopian tube cancer, primary peritoneal cancer, breast cancer at ages less than 50 years old, and breast cancer in a male. Those are all risk factors for cancer. The risk modifications would be a bilateral salpingo-oophorectomy, oral contraceptive use, less than 30 years old at their first live birth, breastfeeding, and tubal ligations. All those decrease the risks of ovarian cancer. All right, so typically it's identified in individuals with breast cancer less than 50 or ovarian cancer at any age. BRCA1 and BRCA2 have a 60% to 20% lifetime risk of ovarian cancer. premenopausal prophylactic bilateral salpingo-oophorectomy is performed, and that will significantly decrease the incidence of ovarian cancer, as well as breast cancer and overall mortality in BRCA carriers. The recommendation, as soon as childbearing is complete, is to counsel the patient regarding the side effects of the bilateral salpingo-oophorectomy from surgical menopause. And you're basically initiating menopause in these patients, and you will counsel them on their decrease in libido, their decrease in bone mineral densities, so their higher risk of osteoporosis, and their higher risk of heart disease. So it's not offered in individuals without hereditary increased risks. So if there are already increased risks due to their hereditary background, then that's not, surgical menopause is not offered. Oral contraceptives are not as effective as bilateral salpingo-oophorectomy, but it still has a protective effect. Screening. For the average risk of patients, like no hereditary cancer syndromes, then no screening tests exist for that. However, very strong family histories of ovarian cancer do require testing for BRCA1 and BRCA2 mutations, preferably starting from an individual's diagnosed with cancer. So epithelial ovarian cancer or epithelial ovarian carcinoma, clinically they present with shortness of breath acutely, obstipation, constipation, vomiting, and abdominal distension. They can also subacutely present with pelvic or abdominal pain and bloating with early satiety, and asymptomatic adnexal masses. On lab findings, you'll have an increased CA125. That's going to be increased, and that's drawn to correlate with clinical findings and to monitor the treatment in the future, but it's a very sensitive test. Ultrasound findings would be a solid mass, thick septations and ascites. A pelvic ultrasound is going to be first line for any kind of palpable adnexal mass, and then a combination of transabdominal or transvaginal ultrasound is used for full overview. Fallopian tubes are not visible unless there's pathology present. On management, you want to do an exploratory laparotomy. So how would you evaluate an adnexal mass in a postmenopausal patient? So somebody comes in about 45, 50 years old, maybe more than that, and you see an ovarian mass on ultrasound. What do you do next? You want to check a CA125. If it is elevated, then you want to check a CT or MRI for any types of metastatic diseases, or you want to even do an exploratory laparotomy surgery. Now, if they do not have CA125 elevation, then you want to check for malignant features, like do they have any solid masses, do they have any thick septations or localizations, or are they large in size? If not, then you want to just continue doing serial ultrasounds and CA125s. However, if they do, again, you want to check a CT MRI and check for metastasis and do an exploratory laparotomy. Even if there's no malignant features present on ultrasound and CA125 is increased, you want to still perform further imaging. So epithelial ovarian cancer refers to a malignancy that involves the ovary, the fallopian tube, and the peritoneum. The abnormality can begin at any of those sites, and it presents with a hallmark of large ovarian masses and a widespread pelvic or abdominal metastasis regarding of the primary origin. So it could either start right there, but most likely it's going to be a metastasis. Risk factors are postmenopausal women, family history of ovarian or breast cancer, like BRCA carriers, nulliparity or use of fertility drugs, and that's usually present with advanced disease as early symptoms are not specific. On physical exam, they may present with a firm non-mobile pelvic mass with nodularity, and that's concerning for for an extension beyond the adnexa. So ascites, this is due to a peritoneal spread, and that causes an increase in capillary permeability and a decrease in intravascular oncotic pressure. CA125 has little specificity in premenopausal women. It can be increased from many benign conditions like endometriosis can cause an elevated CA125, as well as leiomyomas and lupus can cause an increase in CA125. So mainly it's useful in postmenopausal women, and it can also be used to monitor recurrence of proven malignancy after treatment. So it's better the CA125 in a postmenopausal woman, and then if they're under treatment and you want to check the levels, that's when you check CA125. Exploratory laparotomy with cancer resection, staging, and inspection of the entire abdominal cavity is done, especially in acute presentations, and it's a definitive treatment. During surgery, the ovaries, the uterus, the omentum, and any kind of visually apparent cancerous lesion will then be removed, and the pelvic and periaortic lymph nodes are going to be dissected out. Chemotherapy and platinum-based agents are done after the cancer is removed, and then you want to do an image-guided biopsy. I'm sorry, you do not do an image-guided biopsy. That is contraindicated, and because it can cause spread of cancerous cells to the entire abdominal cavity. So that's a no-go for that. You do not image-guide biopsy endometrial cancer, epithelial ovarian cancer. Okay. Granulosa cell tumors of the ovary, clinical features would be a child with precocious puberty, postmenopausal women causing bleeding or endometrial hyperplasia, and a large adnexal mass. Diagnostic findings would be high levels of estrogen and a pelvic ultrasound. An ovarian mass can show a thickened endometrium. This occurs in postmenopausal and rarely in prepubertal girls, and the tumor is going to secrete estrogen, breast tenderness, endometrial cancer, other features in the table. So in this table that we just run over. There's going to be a thickened endometrium on ultrasound, and it requires immediate evaluation for concomitant endometrial malignancy with endometrial biopsy, and that's the gold standard to obtain an endometrial sample is a biopsy. How else are you going to get a sample if it's not a biopsy? So, and then treat is to surgically excise. Now we're going to talk about contraception. So, the physiology of a fertile window. So, you are going to basically have, let me make this easier to read. 1 second. Okay, you're going to basically have ovarian histology. So the primary follicle, basically LH levels are low, and FSH levels are also low. And the uterus is sloughed off, and this is the follicular phase, or day 0. Let's make this a little bit easier. So it's from day 0 to day 14 is your follicular phase. From day 14 to day 28, that's your luteal phase. So during your follicular phase, you have your menses occurring, and that's the sloughing off of the uterine the lineament of the uterus, and you have your primary follicle and secondary follicle at that point. So LH and FSH, the LH is going to be low, FSH is going to be a little bit higher, and they're going to cross somewhere in between day 5. So LH starts becoming more prominent, and FSH starts declining during the end of the follicular phase. By the time you have the mid-luteal phase or the beginning of the luteal phase on day 14, you have your LH levels very high during ovulation, and FSH levels have a little spike as well. And then your corpus luteum regression, and then corpus albicans happens. and that's your luteal phase. Okay, so that was a little confusing to explain, but visually it's better. So just look for a, whenever you have time, just look at the fertility window graph, and that's self-explanatory. But basically what they're showing off is that LH and FSH levels are going to be opposite directions of each other. LH is going to spike in the day 14, and it's going to start going low during the luteal phase. Okay, so fertilization is going to be possible between 24 hours after fertilization, and it takes 6 to 12 days to implant. Emergency contraception options. So there's several methods. There's the copper intrauterine device, the ulipristal pill, the levonorgestrel pill, and oral contraceptives. So let's go with the copper intrauterine device, which causes inflammation. This inflammatory reaction is toxic to sperm and ova, and it impairs implantation. The time after intercourse is, you can put it in between 0 to 120 hours after intercourse, and it has a 99% efficacy, so it's the best one. If you're ever asked what is the best method of emergency contraception, it's the copper intrauterine device. Now you have your ulipristal pill, and that's anti-progestin, and it delays ovulation. Also can be given between 0 to 120 hours after intercourse, and has a more than 85% efficacy. It's more effective than the levonorgestrel pill, but it's also less readily available. So what is the levonorgestrel pill? It is a progestin pill which delays ovulation. It can be given up to 72 hours after intercourse, and its efficacy is around 85%. And oral contraceptive pills in general, they also are progestin based, and they delay ovulation. Again, up to 72 hours after intercourse, but they have the least efficacy at 75%. So that copper intrauterine device is the best, and it's the most effective emergency contraceptive as well as long-term contraception. It needs a professional person to insert it. It has to be inserted inside of the uterus. And it's a hormone-free method, so it can be used in breast cancer patients undergoing treatment for long-term contraception, and that avoids hormonal effects of oral contraceptives. It could be placed for a maximum of up to 10 years. The levonorgestrel intrauterine device can be used too for a long term, but it can be placed for 5 years, and it's not an emergency contraception. It's not good for emergency contraception. Age and parity are not contraindications for the copper intrauterine device. Acute cervicitis and pelvic inflammatory disease, however, are contraindications, and the use in conjugation with condoms is used to prevent STDs. It's because this will prevent you, the copper intrauterine device will prevent you from becoming pregnant, but it won't prevent you from acquiring any type of STDs, obviously. It's not a barrier method. So if you want to combine this with a barrier method, that is a double whammy effect, and that is the best to prevent STDs. Levonorgestrel intrauterine device thickens the cervical mucus, blocks sperm entry, and thins the uterine lining and decreases menstrual bleeding. And then you have oral levonorgestrel, which is also known as Plan B. That is most readily available emergency contraception. I think it's even over the counter in some places. Ulipristal and levonorgestrel are more and more effective before ovulation and has occurred as they prevent oocyte release and delays ovulation. It's ineffective after fertilization, and the efficacy decreases over the course of 72 hours, so give it as soon as possible. Oral contraceptives are for emergency contraception. You have to use multiple pills can be taken, and they have to be taken in 2 doses, 12 hours apart, to achieve an effective progestin level. It may be easy to obtain, but it's less effective. It's way too many directions, and patients will not adhere to that very easily. The benefits, however, of combined oral contraceptives is that you have pregnancy prevention, you have endometrial and ovarian cancer risk reduction, you have a menstrual regulation with reduction of iron deficiency anemia, and a reduction in risk of benign breast disease. The adverse effects of oral contraceptives or combined oral contraceptives is that they can cause a breakthrough bleeding because of the low estrogen dose in drugs. So they have very little estrogen, like 10 to 35 micrograms of estrogen. They can cause breast tenderness, nausea and bloating, amenorrhea, hypertension, venous thromboembolic disease. There's a decreased risk of ovarian and endometrial cancer with an increased risk of cervical cancer. Liver disorders like hepatic adenomas and increased triglyceride levels due to estrogen component. There's a history of a benign breast disease or family history of breast cancer is not a contraindication for oral contraceptive use. So that's kind of good. That can be an option for patients with family history of cancer, of breast cancer, or if the patient has a benign breast disease. Patients with uncontrolled hypertension who smoke and are older than 35 should consider some other form of contraception. Controlled hypertension can be given. They can be given oral contraceptives, but with blood pressure monitoring to ensure ongoing control. The weight gain, though some clinicians believe that oral contraceptive pills can cause weight gain, but really they don't. So there's a specific question where which of the following is not a adverse effect of oral contraceptives, and it's weight gain. They do cause hypertension, but they don't cause weight gain. Though some clinicians think so, it's false. They don't. Old high-dose combinations of oral contraceptives were associated with weight gain, but the new lower dose formulations don't cause weight gain, so you should just reassure the patients. Medroxyprogesterone causes an increased body fat and decrease in muscle mass, so that's not relatively good. And then contraindications of oral contraception. So these are absolute contraindications to combined oral contraceptives. So you can't give them if the patient has a migraine with an aura, if they smoke more than 15 cigarettes a day and they're older than 35, if they have stage 2 hypertension, because they do cause hypertension. So if they already have stage 2 hypertension with a blood pressure of more than 160 over 100, that's contraindicated. If they have any type of history of thromboembolic disease, any type of history of stroke or ischemic disease, if they have a history of breast cancer, especially in hormone receptive positive breast cancer, like a BRCA2, or BRCA2 carriers tend to have estrogen receptor positive breast cancer, and all types of hormone containing contraceptives are basically contraindicated, including progesterone, intrauterine devices, the patch, and the vaginal ring. Also, cirrhotic patients and patients with liver cancer have contraindications, and patients that have had major surgery with prolonged immobilizations are contraindicated, and less than 3 weeks postpartum are contraindicated. All these can cause thrombosis and strokes, so no good. Progestin-based pre-coital contraceptives are your depot-medroxyprogesterone acetate and the etonogestrel subdermal implant. These are systemic progesterone-based precoital contraceptives, and that inhibits the secretion of GnRH from the hypothalamus, causing a decrease of FSH and LH, and that inhibits follicular development. They don't work as an emergency contraceptives because they have no efficacy on already maturing ovarian follicle. Depot depot-medroxyprogesterone acetate can be given intramuscularly every 3 months, with side effects such as menstrual irregularities, such as prolonged bleeding and spotting, especially during the first 6 months. About 50% have amenorrhea for about a year's use. Fatigue, nausea, weight gain, breast tenderness are less common, but persistent throughout the use of depot-medroxyprogesterone acetate, and symptoms may mimic pregnancy. Contraception in lactating mothers. So what if they're lactating? Do you give them oral contraceptives? It's acceptable. Contraceptive methods in postpartum periods would be sterilization, a barrier method, intrauterine device methods. Progestin-only pills are preferred hormonal contraceptives in lactating women because they don't affect the volume or composition of the milk produced by the mother, and there's no known side effects or effects on the infants, and no increased risks of venous thrombosis. So progestin-only pills are good. And combined oral contraceptives, they decrease milk production and pass in milk. So the effect on the infant is unknown. So that wouldn't be very good. I wouldn't pick that because of the decrease in milk production. It's not good. Okay, SERMs, or selective estrogen receptor modulators. SERMs are drugs such as tamoxifen or raloxifene. Their mechanism of action is that they're competitive inhibitors of estrogen binding sites, and it's a mixed agonist-antagonist action. Their indications are for the prevention of breast cancer in high-risk patients. Tamoxifen specifically is an adjuvant treatment for breast cancer, and raloxifene is used in postmenopausal osteoporosis. So adverse effects, they both can cause hot flashes. They both cause venous thromboembolisms by causing resistance to protein C. And they both will cause endometrial hyperplasia and carcinoma. It's actually only tamoxifen will cause endometrial hyperplasia and carcinoma. You can relax with raloxifene. Is the mnemonic there. Relax with raloxifene because it won't cause endometrial hyperplasia or carcinoma. However, tamoxifen does. Adjuvant endocrine therapy is commonly used for non-metastatic hormone receptor positive breast cancer, and most commonly used endocrine agents are going to be your tamoxifen, aromatase inhibitors, and ovarian suppression via medicine or surgery. So tamoxifen. Tamoxifen is premenopausal at low risk of recurrence. It's preferred endocrine drug for adjuvant treatment. It's associated with endometrial polyps. For postmenopausal patients, it is second line. It's prescribed to those who cannot use aromatase inhibitors. It is associated with endometrial hyperplasia and cancer, and there's a risk that lasts for the duration of the therapy that resolves after discontinuation of the treatment. So the benefits here outweigh the risks, and it also decreases the risk of cancer recurrence and the development of new cancer in an opposite breast. However, hot flashes do occur at 80% of patients taking tamoxifen. It is an anti-estrogenic activity on the central nervous system and causes thermoregulatory dysfunction in the anterior hypothalamus, similar to a menopausal hot flash. Raloxifene, however, is less effective than bisphosphonates for osteoporosis, yet it's still used in postmenopausal women who can't tolerate bisphosphonates or have an increased risk of breast cancer. All medications with estrogen agonist activities, like oral contraceptives or hormone replacement therapy or SERMs, selective estrogen receptor modulators, they are contraindicated in patients with current or past venous thromboembolisms because this can cause thromboembolisms. Raloxifene actually decreases the total and LDL, the total cholesterol and the LDL, but it does not increase or decrease the risk of coronary artery disease, but coronary artery disease and estrogen receptor positive breast cancer is contraindicated for hormone replacement therapy, regardless if it decreases the risk or whatnot. It's contraindicated if there is a estrogen receptor positive breast cancer. Ovarian hyperstimulation syndrome. It's an iatrogenic complication of ovulation-inducing drugs. Abdominal pain is due to ovarian enlargement and may be accompanied by ascites, respiratory difficulty, and other systemic findings. So what are the systemic effects of DES in pregnancy? So, like we said earlier, DES causes clear cell adenocarcinoma of the vagina and the cervix. It causes structural abnormalities of the reproductive tract, like a hooded cervix, a T-shaped uterus, a small uterine cavity, vaginal septations, and vaginal adenoses. Pregnancy problems would be like ectopic pregnancies and preterm delivery, as well as infertility. Now, clear cell adenocarcinoma can occur at any age, but the peak incidence is in teens and in their 20s. The complication in boys exposed to DES in utero would be cryptorchidism, a microphallus, hypospadias, and testicular hypoplasia. The use of DES was used to prevent spontaneous abortion, premature delivery, and postpartum lactation suppression. So that's why they were given that to begin with, but it's not good. All right, so we are now going to be talking about the breast. So we just finished all of the vagina and endometrium, cervix. So now we're going to talk about the breast. So the evaluation of nipple discharge. So if you have nipple discharge, you want to see if it's unilateral or bilateral. Nipple discharge, if it's unilateral, that's a pathological discharge, and you want to check that out with a breast ultrasound and mammography if they're older than 30. Also, nipple discharge, you want to check out the color of the discharge. If it's bloody or serous discharge, then it's also pathological. Again, do a breast ultrasound or mammography. However, if it is milky or non-bloody discharge, then you want to check for any lumps. If there is a palpable lump or any kind of skin changes, again, that's pathological, so breast ultrasound or mammography. If not, then it's likely a physiological discharge. So basically, if it's a bilateral nipple discharge that's not bloody, not milky, there's no serous discharge, that's physiological discharge. So you want to check out a pregnancy test with a beta-HCG, a guaiac test, serum prolactin levels, TSH levels, and you also want to consider an MRI of the pituitary, because in patients with high prolactin or symptoms or those with high prolactin levels, then you're going to think of a prolactinoma or a pituitary mass. So also look for, in that case, bilateral temporal hemianopia. So we'll get to that in a little bit. Physiological galactorrhea. Galactorrhea is a lactation in men and non-breastfeeding women. This can be a sign of significant pathology. Usually it's bilateral and guaiac negative. Typically it's milky or clear, but it can be yellow, brown, or gray, or green. And the most common causes would be hyperprolactinemia. That can be due either because of a pituitary prolactinoma, as we said earlier, medications that inhibit dopamine, hypothyroidism, pregnancy, and chest wall or nipple stimulation, such as surgery, trauma, or shingles. So let's say you do have a palpable breast mass. You want to see if they're younger than 30 years old or older than 30 years old. If there's a palpable breast mass and they're younger than 30 years old, the next thing you want to do is an ultrasound with or without a mammogram. You want to focus on the ultrasound first. So ultrasound will show you either a simple cyst or a complex cyst or a complex mass or solid mass. So if it's a simple cyst, you just want to needle aspirate that if the patient wants to. If not, you don't. If it is a complex mass or a solid mass or a solid cyst, you want to do an image-guided core needle biopsy. However, if you do have a palpable breast mass in a woman that's older than 30, in this case you want to do mammogram first. Then you want to do ultrasound, maybe or maybe not, but mammogram first. If it's suspicious for malignancy, then you want to do core biopsy. So remember that in a young woman with a palpable breast mass, if it's mobile or tender, it's likely benign. A simple breast cyst, the presentation is variable with no symptoms to severe localized pain. On ultrasound, this shows an acoustic enhancement indicative of fluid and no echogenic debris or solid components. Symptomatic patients can benefit from aspiration and should yield a clear fluid, the disappearance of the mass, and thereby confirm the diagnosis. A cystic fluid can reaccumulate, hence there's a clinical breast examination follow-up 2 to 4 months later with no further signs of symptoms of recurrence. Then you want to do an annual screening. And if it reappears or it does not reappear after aspiration, you want to do a core needle biopsy. Now, if the patient's more than 30 years old, remember screening mammogram first. That's used for asymptomatic women without masses. Diagnostic is a multiple view mammogram that's used to evaluate palpated masses and abnormal screening test results. A targeted ultrasound is used to characterize the mass, and it's often done alongside a mammography. If it's a solid acellular mass, that's most likely a stromal mass, so you want to do a core needle biopsy. If it's a large or suspicious mass, you want to do an excisional biopsy. And if you're suspecting a cyst or small mass, then you want to do fine needle aspiration. So core biopsy for solid masses, excisional biopsy for large masses, and a fine needle aspiration for small suspected cystic masses. So now we're going to talk about benign breast diseases. Okay, so you have, under benign breast diseases, you have breast cysts, you have fibrocystic change, you have a fibroadenoma, and you have fat necrosis. So a breast cyst is a solitary, well-circumscribed mobile mass with or without tenderness. Since it is a cyst is fluid-filled. So the treatment is to fine needle aspirate some of that fluid or drainage of that cyst. For fibrocystic change, this is multiple diffuse nodulocystic masses with cyclic premenstrual tenderness, and the symptoms improve during or after menstruation. The patients can be offered NSAIDs or oral contraceptives for symptomatic relief. For a fibroadenoma, this is a solitary, well-circumscribed mobile mass, and it has a cyclic premenstrual tenderness. Fat necrosis is due to trauma, post-surgical trauma, or any kind of trauma. Firm, irregular mass is seen with or without ecchymosis or bruising, and skin nipple retraction. So those are all benign. So let's delve in further with a fibroadenoma. Fibroadenomas happen younger than 30 years of age. Clinically, they are single unilateral mobile masses that are well circumscribed. They do have pain, and they have an increase in size prior to menses, so the mass does change in size according to their periods. Management is through observation and reassurance in an adolescent, or if they're a little older, you want to check an ultrasound if you see that if the mass persists. Remember, if they're less than 30 years old, breast mass ultrasound. More than 30, mammogram. Less than 30, ultrasound. More than 30, mammogram. Okay, the pathogenesis is fluctuating estrogen and progesterone levels for a fibroadenoma. You want to re-examine over the last menstrual cycle right after menstruation, and if the size changes or there's tenderness, no further workup is needed. And an excisional biopsy is indicated in adult patients or those with very large masses. Now, fat necrosis is clinical, and radiographic findings may mimic breast cancer, but usually it presents as a fixed mass. On mammogram, there's calcifications because it's a trauma. On ultrasound, there's a hyperechoic mass, often correlated with a benign etiology. Biopsy is diagnostic, and it shows fat globules with foamy histocytes. And despite benign biopsy results, the entire mass is often excised due to the calcifications on mammogram and fixed irregular masses on exam. So you want to take that out because it calcifies and it can hide other masses that can present itself later. So just remove it. And then once the diagnosis is confirmed with pathological analysis, you want to do a routine annual screening if there's sufficient or no increased risk of cancer. Intraductal papillomas. The clinical features here are unilateral bloody nipple discharge with no associated masses or lymphadenopathies. And the management would be to do a mammogram and ultrasound, and you want to biopsy that lesion with or without excision of the lesion for confirmation of the diagnosis and for subsequent pathological evaluation. So an intraductal papilloma is a benign condition. The discharge can be either brown or pink or red, and it's confined to a single duct and can range from frank blood to serosanguineous blood. So if you have bloody nipple discharge, that's benign. It's an intraductal papilloma. Mammogram on ultrasound will reveal normal breast tissue or a single dilated breast duct. Malignant breast tumors is the next topic. So what are the risk factors for breast cancer? They are classified either in modifiable or non-modifiable. So what are the modifiable risks? Modifiable risk would be things that you can change, like the use of hormone replacement therapy, nulliparity, increased age at the first live birth, alcohol consumption, obesity. Even low alcohol intake, less than a drink a day, increases the risk of breast cancer in women. So moderate consumption, which is less than 2 drinks a day or less than 7 drinks a week, although moderate decreases of overall mortality and possible cardiovascular benefits, it does have a dose-dependent causal effect on breast cancer. It also increases the risk of head and neck cancer. So alcohol decreases the risk of cardiovascular problems, but can cause breast problems. So it's always, there's a question there that says that when patients drinks 2 glasses of wine a day or something, and you're asked what can she do to easily reduce her risk of breast cancer, and it would be to decrease the level of consumption of alcohol. You would think 2 glasses of wine a day isn't that bad or beneficial, but actually it's not for breast cancer. So those would be modifiable risk factors. Non-modifiable ones would be like genetic mutations or breast cancers in the first degree relatives. These are things that you can't change. Breast cancer less than 50 years and ovarian cancer at any age of a first degree relative requires genetic mutation testing. If you're white, if your race is white, if they have an increased risk of breast cancer. Increasing age, the older you get, that's not modifiable. And early menarche and late menopause. All these are not modifiable. So exercise and breastfeeding is also protective. Menarche at age greater than 13 also decreases the risk, and oral contraceptive use decreases the risk of ovarian cancer, but oral contraceptives do not decrease the risk at all for breast cancer. The screening test for breast cancer is that there's a clinical breast examination and mammography. Routine mammography at ages more than 50 is due to an increased risk of cancer with increasing age. So an MRI for BRCA carriers, first-degree relatives with BRCA carriers, and pre- or post-management of breast cancer is done. So what are some of the important prognostic and treatments? So prognostic factors in decreasing order of significance. So number one would be tumor burden-based TNM staging. That's always number one, is to actually grade and stage the cancer. Number two would be estrogen and progesterone, which are good prognostic factors. HER2 new oncogene overexpression is the worst prognosis, and a histological grade would be poorly differentiated tumor has a very, very bad prognosis. Also, a size more than 2 centimeters is known as T2. Breast conserving surgery is followed by chemo and radiotherapy. The presence of overexpression of HER2 oncogene is an important prognostic factor and treatment factor, and it's determined by fluorescence in situ hybridization, or FISH, or immunohistochemical staining. So HER2 overexpression positive, you want to treat with trastuzumab, also known as Herceptin, and that specifically targets cells that cause overexpression of the oncogene. Trastuzumab is used as an adjuvant therapy in early stages of the disease or in later stages that metastasize. Side effects would be cardiotoxicity, and an echocardiogram is done or recommended before therapy to determine a baseline function or future references to consider other therapies if there's poor baseline heart function or if there's a borderline or low ejection fraction, because trastuzumab is cardiotoxic. HER2 overexpression also affects chemotherapy regimens used, so anthracyclines are more effective. Initially, HER2 overexpression was associated with a poor prognosis before targeted therapy, but now the prognosis is even less clear. So, next topic is non-invasive breast cancer. And non-invasive breast cancer would be like Paget's disease of the nipple, which shows up as persistent eczematous and or ulcerating rash localized to the nipple that spreads to the areola. The vesicles causes bloody discharge of the nipple, and nipple retraction may be positive. 85% of the time, there can be an underlying disease of breast cancer, and adenocarcinoma are the most common types of breast cancers and can also cause Paget's disease of the nipple. So if you're thinking Paget's disease, that's an adenocarcinoma. It's due to a migration of neoplastic cells through the mammary ducts all the way to the nipple surface, and the workup is to do a mammogram and a biopsy. And finally, invasive breast cancer is a type of inflammatory breast cancer. It's a rare but aggressive cancer that is rapid in onset, edematous cutaneous thickening of the peau d'orange appearance, or the orange peel appearance. It causes itching and a palpable mass with nipples that can be changed or retracted. It can also be confused with an infection. You're thinking infection, you give them antibiotics, but if they don't respond to the antibiotics, you should be thinking of a type of inflammatory breast cancer. So the evaluation here would be to do a mammography and an ultrasound, as well as tissue biopsy to confirm it. So some pointers for this chapter would be to rule out pregnancy in a sexually active woman of childbearing age presenting with an acute abdomen or nausea and vomiting, abdominal bloating, constipation before performing ultrasound and any other type of imaging studies, as well as a serum pregnancy test because it's more sensitive and can be positive within 4 days of implantation. However, if they have a pregnancy test that's positive, the next thing you want to do is a pelvic ultrasound to use to evaluate intrauterine or an ectopic pregnancy or an ovarian pathology. If they have a negative ultrasound, you can do a CT scan to consider or rule out other causes like appendicitis, kidney stones, or you can do an X-ray to rule out intestinal obstructions or perforations. Menopause and hyperthyroidism can have similar symptoms, so that's why patients with history suggesting both of them should be tested with TSH and FSH. So if you're thinking hyperthyroidism or you're thinking a menopause patient, you got to check TSH and FSH levels. If there is high thyroid releasing hormone, TRH, and high serotonin, low dopamine, like antipsychotics or TCAs or MAOIs, hypothalamic and pituitary tumors, this all causes an increase in prolactin and a decrease in GnRH and gonadotropin production. So all that will cause amenorrhea and galactorrhea. And that is the end of female reproductive system. So next would be female reproductive system in pediatrics. So here it's a little bit easier. You have to worry about vaginal foreign bodies. It's a common cause of vulvovaginitis in prepubertal children. Toilet paper is going to be the most common cause of vaginal foreign body, although small toys and other objects can be seen. Presenting symptoms are going to be a foul-smelling vaginal discharge with intermittent vaginal bleeding and spotting, and occasionally they'll complain of urinary problems, pain on urination, dysuria or whatnot. There could be, when there's a vaginal foreign body is suspected, then an external examination of the genitalia should be performed with the child in either a kneaded chest or a frog leg position to examine, to minimize the discomfort. And depending on the age of the child and the size of the type of the foreign body, sedation or general anesthesia can be required, both to examine the foreign body and remove it. Small foreign bodies such as toilet paper and toys, small toys, can be often removed easily with calcium alginate swabs or irrigation with warm fluids after a topical anesthetic has been applied. If those techniques are unsuccessful and don't work, or if there's a very large foreign body, then examination under anesthesia may be necessary. Remember that bimanual examination should never be performed in prepubertal children. Maternal estrogen effects on newborns. So what is mom's estrogen going to do to the newborn? In girls and boys, they will have breast hypertrophy, a swollen labia, physiological leukorrhea, which is a white vaginal discharge, and uterine withdrawal bleeding. So it's almost like the mom says, my baby just had a period. No, it's uterine withdrawal bleeding. That's completely normal. Female infants less than 3 months sometimes develop vaginal spotting or bleeding, and that is an odorless, cloudy, white vaginal discharge that's mixed with blood. And pathophysiology would be maternal estrogens that can cross the placenta and enter the fetal bloodstream before birth, and pubertal effect on the newborn. Effects disappear as soon as the hormone is cleared from circulation, hence there's a routine care and reassurance should be provided. Then finally you have premature thelarche, which you need assessment of ovarian ultrasound and an FSH and LH level, useful in patients with premature thelarche presenting after infancy. And thelarche being premature breast development. GnRH stimulation test is done for precocious puberty before age 7 if there is premature thelarche. And that is the end of what was this? It's the end of female reproductive systems of pediatrics. The next one is male reproductive system, is another small one. You have priapism, which the common causes of priapisms would be sickle cell disease and leukemias, usually in children or adolescents. Perineal or genital trauma that results in laceration of the cavernous artery. Neurogenic lesions such as spinal cord injury or Kautokeino syndrome, etc. And medications such as trazodone and prazosin. This is the most common cause of priapism is prazosin. Impotence, drugs associated with impotence. Most antihypertensives are associated with impotence, such as enalapril, and non-selective beta blockers like propranolol. There's acute urinary retention in the elderly men, and the causes of that would be obstruction and neurogenic bladders of the detrusor muscle inactivity. And the most common cause in elderly men is BPH for urinary retention, or a prostatic cancer. Post-void dribbling, a decrease in stream, urgency and hesitancy, nocturia, and urinary retention. Achilles tendon reflexes can decrease or become absent in elderly, and it's not indicated of spinal cord injury. Spinal cord compression in the lumbar region causes lower extremity weakness, bowel bladder incontinence, and rather than retention, and a decrease in rectal tone with brisk lower extremity deep tendon reflexes. Prostatitis. So prostatitis, you have acute and chronic prostatitis. So clinically, in acute, they present with fevers, chills, malaise, myalgias, pelvic pain, and cloudy urine. The diagnosis is done with pyuria and tender prostates. Urine culture is positive for E. coli, and you want to treat with TMP-SMX or fluoroquinolones. For chronic prostatitis, they present with dysuria and increasing urinary frequency. There's no symptoms of acute prostatitis. There's a recurrent urinary tract infections and pyuria. Diagnosis is with pyurias with possible tender prostate and urine culture positive, usually E. coli. Treatment here is fluoroquinolones. So acute bacterial prostatitis is usually caused by the same organisms that cause other infections of the urinary tract, like E. coli, Proteus, and Klebsiella. Initial symptoms may resemble cystitis, but systemic symptoms are more pronounced than prostatitis. Even if leukocyte esterase is positive on dipstick, you want to perform a midstream urine culture to help detect antibiotic therapy. So because of the culture, you can determine what's causing the infection, hence what is that infection more susceptible to, and you can direct antibiotic therapy to that. Then you have prostate massage to increase culture yield has been recommended. It's painful and may induce bacteremia, however. Antibiotics started while awaiting culture results. Treatment should be continued for 4 to 6 weeks in most cases. And a CT scan can be useful to diagnose prostatic abscesses, which would be suspected if a patient has acute bacterial prostatitis that continues to have fever despite having antibiotic therapy. So fever that persists with antibiotic therapy and prostatitis, you should think a prostatic abscess. Now you have non-inflammatory chronic prostatitis and inflammatory chronic prostatitis. So non-inflammatory chronic prostatitis is afebrile. It's irritative voiding symptoms that have frequency, urgency, hesitancy, and an interruption of flow. Physical exam is unremarkable. There's mild periprostatic tenderness can be present. Urinalysis is normal. Its expressed prostatic secretions show a normal number of leukocytes, and culture of these secretions is negative for bacteria. There is usually no history of past UTIs, but avoiding abnormalities may be present in the past. Inflammatory chronic prostatitis are afebrile, irritative, voiding symptoms like urinary frequency, urgency, and suprapubic or perineal discomfort. Urinalysis is normal, and its expressed prostatic secretions show a leukocyte count greater than 10 white blood cells per hypouric field, and cultures of these secretions are negative. So what is a screening for prostate cancer? The USPSTF, the U.S. Preventive Screening Task Force, does not recommend screening using PSA irrespective to age. This states that screening does not save lives and leads to more tests and treatment that needlessly cause pain, impotence, and incontinence in many patients. So the American Urological Society of American Cancer Society recommends screening with a PCA in conjunction with a digital rectal exam at age 40 with counseling of risks and benefits of screening. The recommended screening in patients up to age 75 years old with life expectancy of at least 10 years. As a result of this controversy, screening decisions are left up to individual and physician, and it's determined by the discussion of risks and benefits. Finally, testicular cancer. After the diagnosis of testicular cancer has been made, which is basically a hard, palpable, painless testicular mass that's suggestive with ultrasound, the initial management is to remove the testicle entirely and its associated cord, and an orchiectomy is done through small inguinal incisions, and this procedure is called a high inguinal orchiectomy. The testes and an abnormal tissue is present, is then examined under a microscope to determine the type of cancer. It depends on the type. Other therapies such as additional surgery, radiation therapy, or possible chemotherapy may be indicated. The highest cure rate of all cancers achieved by a combination of surgery and chemotherapy is with radiation in some cases. The cure can be achieved in cases of cancer spread to other parts of the body. In this tumor, we kill first and investigate later. Hence, the biopsy is not the next step. Fine needle aspiration or scroll biopsies are contraindicated due to a risk of spillage of cancer cells and spread through the blood vessels and lymphatics. And that's the end of male reproductive system. And finally, we're going to go over male reproductive system in pediatrics. So cryptorchidism, the risk factors are prematurity, small for gestational age children, low birth weights, in utero exposure to diethylstilbestrol and pesticides, as well as genetic disorders and neural tube defects. Clinical features show an empty, hypoplastic, poorly rugated scrotum or hemiscrotum with or without inguinal fullness. Treatment would be an orchopexy before the age of 1. Complications would be an inguinal hernia, testicular torsion, or subfertility, as well as testicular cancer. The most common congenital abnormality of the genital urinary tract is cryptorchidism. It could be unilateral, and that usually has no other abnormality, or bilateral, that may have one or many manifestations of an endocrinopathy or genetic syndrome. Regular scrotal exam should be performed on all boys to evaluate testicular location and scrotal appearance. A normal scrotum shows a thick and rugated scrotum that contains palpable testes. Testicles that have not descended by age 6 months are unlikely to descend spontaneously and do require surgery. An orchiopexy is almost all patients have associated patent process vaginalis that is repaired concurrently to prevent inguinal hernias. A testicular torsion risk is removed as the testes are surgically affixed to the scrotal wall. Early surgery improves fertility, but sperm count and quality remain substandard. Pubertal surgery also decreases but does not eliminate testicular cancer risk. Cancer detection also improves as abnormal testicular masses are more easily palpated in the scrotum compared to the groin and the abdomen. So what's a hydrocele? A hydrocele by definition is a fluid collection within the process or tunicus vaginalis, the peritoneal projections that accompany the testes during its descent into the scrotum. So there's different types of hydroceles. You have communicating hydrocele and non-communicating hydrocele. Communicating hydrocele is when the process vaginalis fails to obliterate. That's a test question. It fails to obliterate. Peritoneal fluid may accumulate within the process vaginalis and frequently reducible, but it may also increase in size with valsalva. Non-communicating hydroceles are a collection of fluid within the tunica vaginalis that has properly obliterated its communication with the peritoneum. A hydrocele can be differentiated from other testicular masses by transillumination. A hydrocele will transilluminate while other masses will not. So the management of most hydroceles for both communicating and non-communicating will resolve on its own by 12 months old and can be safely observed during that period. So a communicating hydrocele that fails to resolve in 12 months is unlikely to resolve spontaneously, so that puts the patient at increased risk of indirect inguinal hernias, hence that's why you would need surgical intervention. And that's the end of male reproductive system in pediatrics. And finally, our last topic here is male reproductive system in surgery. So what are the surgical questions they can ask of the male reproductive system? And it's penile fractures and varicoceles, as well as spermatoceles and intestinal hernias. So let's go over them. It's really quick. A penile fracture is typically not injured in a flaccid state by a blunt trauma. It's usually injured during erect positions, mostly during sexual intercourse, especially when a woman is on top. There's a snapping sensation and or a sound followed by severe pain. The snapping sensation is from the tearing of the tunica albuginea, which invests the corpus cavernosum. The hematoma rapidly forms at the site of the injury, bending the shaft of the penis at the site of the fracture. Treatment is with emergent urethrogram to assess for a urethral injury, as well as emergency surgery to evacuate the hematoma and to try to fix the torn tunica albuginea. I always have trouble pronouncing that word. Surgical exploration is the treatment of choice for penile fractures, but it should always be preceded by a retrograde urethrogram to rule out a urethral injury. This is important because of an occult urethral injury may be exacerbated by placement of a Foley catheter. A varicocele, next topic is a varicocele. So its clinical presentation is a soft scrotal mass, which is your bag of worms, that decreases in a supine position, so no bag of worms when they're laying down, and increases with standing or Valsalva maneuvers. There's subfertility in these patients with testicular atrophy. On ultrasound, you'll see a retrograde venous flow with tortuous anechoic tubules adjacent to the testes and dilation of the pampiniform plexus veins. Treatment is gonadal vein ligation in boys and young men with testicular atrophy, as well as scrotal support and NSAIDs in older men who do not desire additional children. 20% of postpubertal men suffer from varicocele, and it's more common on the left than on the right-hand side. Patients may have no symptoms or dull scrotal aches while standing, and the mass does not transilluminate. A spermatocele, however, is a painless fluid-filled cyst at the head of the epididymis. They're located in the superior pole of the testes and contains non-viable sperm. They are distinguishable in physical examination as a mass outside of the testes that does not change with position. And finally, the last topic are your intestinal hernias. Intestinal hernias can cause a painless or painful scrotal masses with a protrusion pattern similar to a varicocele that worsens with standing, Valsalva maneuver, and goes away when they lie flat on their back or supine. So there's a widening of the femoral ring can lead to a femoral hernia. Femoral hernias occur most commonly in older women, however, and this diagnosis is uncommon in men compared to a varicocele. So circumcision is going to be the treatment of choice for phimosis, paraphimosis, and Zuhn's balanitis. It's also associated with a lower risk of squamous cell carcinoma of the penis. I skipped the hernia section. So what are your groin hernias? So to understand the groin, understand the hernias, you have to locate where they're coming from. So you have to picture the rectus abdominis muscle, the inferior epigastric vessels, and the indirect inguinal ligament. All right. So a direct inguinal hernia goes directly through the Hasselbeck's triangle, and that's found below the inferior epigastric vessels. Or actually, it's to the medial of the epigastric vessels, specifically medial of the femoral vein, lateral to the rectus abdominis muscle, and inferior to the inguinal ligament. Now, a femoral hernia is through the femoral ring, which is found inferior to the inguinal ligament, medial to the femoral vein, and lateral to the rectus abdominis muscle. So the best way to figure that out is just by looking at a picture. It's really hard to explain. There's a mnemonic called navel, nerve, artery, vein, empty space, and ligament. If that makes it, and it starts laterally to medial, so you can more or less localize yourself in that area. Other than that, that's pretty much it. Thank you all for your time. This was a 3-hour lecture. That was basically about the time that it takes to go over specific chapters and or sections of UWorld. Next is obstetrics and gynecology. So I look forward to doing this again.